am just going to give you an overview of the program and how it got conceptualized. We are just going to have two talks and then a very interesting panel with the panelists who are all stalwarts of fetal medicine in their own countries. And that panel will be moderated by myself and Dr. Chinmay Rath. And we will have two talks, Dr. Vivek Kashyap and Dr. Lulla. Initially, we just started with a small planning of a small program when Dr. Vivek Kashyap called me that we should have a common platform to discuss, because the world is becoming small and getting better connected with the IT, and there are going to be new challenges faced by the obstetricians and gynecologists in future because of after the corona, and let's make some program. So I really, two pillars of my strength are Dr. Alpesh Gandhi and Dr. Firdausi Begum. I called up Dr. Alpesh Gandhi. Alpesh bhai, he is my president. I said, I want to start and we want to take up this imaging master classes and start it on a common platform. And he agreed very, very, happily that yes, go ahead. And Dr. Firdausi also really supported me very well on this. So we are here today in this masterclass to learn and to interchange and exchange the ideas of all neighboring countries, how they are really doing in cases of a most challenging situation in obstetrics is preterm FGR. And I have this pleasant duty also to introduce and welcome President Dr. Alpesh Gandhi. What can I say about Dr. Alpesh Gandhi? He is a man with an iron will, man with a great vision, and man who has taught us not to be, scared and feared of any tough situations. We took over on 30th January in Lucknow, and he had great plans for over the year. But when the corona came in, we all thought, oh my God, how is it going to be? But he led the way, he led the path, and you can see how Foxy has not even went into lockdown, even during the corona times, and he took us, he kept us alive, he kept us on our toes, and he took the Foxy forward with GCPR. I'm sure he's going to talk about all that, but he is a man with a great vision, and we look upon him as a great leader who has shown us the path even in the dark days. He's a great academician, and he is a fellow of Royal College of Obstetrician and Gynecologist as well, and runs a very successful practice. And I present to you President Foxy 2020 to address the audience.
Thank you very much, Dr. Archana. Thank you very much for the kind words, kind introduction, and appreciating the work done by Foxy. We all are the part of Foxy, and you are on a very important position, and you all are doing a great work. First of all, what we could do is because of the support from all the office bearers. Otherwise, we could not have done all these things. We all are working jointly for the upliftment of women's healthcare in India. And I am thank you for supporting me and working actively for Foxy's vision. A very good afternoon to all the eminent faculties and dear viewers. I extend a warm welcome on behalf of Foxy, and I must congratulate Dr. Archana and Firdausi Begum for this very, very important, useful academic program. I must congratulate all Foxians and all the members of SAFOG for continuing essential and time-sensitive medical services like maternity services, abortion services, and many more in this difficult time of COVID-19 pandemic. You all are doing a good work and great service to the mankind. intrauterine fetal growth restriction leading to a significant perinatal mortality and morbidity, and subsequent also long-term deficit. We all know that placental insufficiency is the principal cause of fetal growth restriction, which in turn underlies a chronic undersupply of oxygen and nutrients to the fetus. The neonatal morbidity associated with fetal growth restriction and preterm depend on the timing of the onset of placental dysfunction, growth restriction, its severity of the growth restriction, and the gestational age at which the birth is conducted. Better understanding of clinical presentation, utility of diagnostic tools like color Doppler, and management strategies of neonatal morbidity and preterm associated with preterm and FGR will enable detection, monitoring and management of potential adverse outcomes in the newborn, which can include even stillbirth. So we are always in dilemma when to conduct delivery, how to monitor continuously up to which gestational age we should continuously do monitoring. I think for this very, very important topic, I must congratulate once again Archana Basar for keeping this useful topic for today's webinar. As she has mentioned, the theme of FOGSI for this year is safety first. Safety for whom? Safety for all women, safety for our tiny patients, fetus and neonate, and safety for all our colleagues, all our doctors. And this is very, very appropriate in this time of COVID-19. We have to be more cautious. We have to be more watchful, and now we should be more active to take care of women, fetus, neonate, and at the same time ourselves. With this brief, I would not take much time. Yes, of course, Dr. Archana has mentioned what FOGSI has done. We came out with the GCPR, with frequently asked question booklet, with our national registry. We are getting very good support. We are collecting a huge number, we have collected a good number of data in this national registry. We came out with the second version. We also came out with the guideline on SRH and gynecology and COVID-19. So we have done lots of work. We have donated a huge amount to our Prime Minister Cares Fund. At all the front, we have done whatever is possible by us at FOGSI level. With this brief introduction, I would not take your much time, and I wish all of you a great learning, happy learning, and I wish a great success to this webinar. I hand over mic to Dr. Archana. Thank you very much. Wishing you safety. Thank you.
Thank you, Dr. Alpesh, for your kind words and encouraging remarks for this workshop and masterclass. And we appreciate your words. And I'm sure we will have good discussions here and good talks. So now let's take on our next President SAFOG, Dr. Firdausi Begum. Is she here, Dr. Firdausi Begum?
Yes, she is here.
Yes. Firdausi Begum is another my pillar of strength. I mean, I have bothered her so much for small things. She has been a guide, and she is a woman with an eagle's eyes. Let me tell you, she will read every finer details which is being written, and she will say, Archana, you have to do this. And she has been a really great to work with. And let me introduce her to you all. She is President SAFOG, and she's professor and head of Department of Obstetrics and Gynecology at Ibrahim Medical College and Birdem Hospital, Dhaka. And she has many publications to her credit, and she's editor of Journal of Obs and Gynae of Bangladesh, editor Journal BPS. She's focal point Bangladesh FIGO Initiative for Prevention of Unsafe Abortion, and she is a great teacher and a great friend and a great academician. So let me present to you Dr. Firdausi Begum, and she's just going to take us her speech and address to us.
Thank you very much, Dr. Rachana, for your kind words. First of all, good afternoon to everyone, and assalamu alaikum. Peace be upon all of us. So, first of all, I must address my past presidents of SAFOG, Professor T.H. Choudhury sir, Professor Farooq Zaman, Professor A.B. Bhuya. I think these three are present so far here. Thank you for sir joining. Dr. Alpesh Gandhi, great friend. I must, maybe this is not the proper place, but I must thank you because, sir, many of us, you don't know that one of our colleagues in last Lucknow conference, FogsiSafogJuly252020, he fell ill. He had a cardiac arrest, a heart attack suddenly. And the way Dr. Alpesh and the whole FogsiSafogJuly team responded, I salute you for that. And he's well now, he's good. So thanks for everything, including this. And Dr. Sadhana is there. Dr. Archana, I must say, Alpesh, you have a very good hand. She is so nice. She's so nice. She's a good organizer. At the same time, she understands where to oblige, where to raise her voice. Thank you so much. And Dr. Yusuf is here. Everyone who are present in the audience, the speakers, panelists, everyone. So welcome to all of you. This, we know that especially in the developing countries, what is happening, that the rate of preterm rape is coming down to say about how to save our newborns. So, but the stillbirth growth, every one of us know that the stillbirth growth rate is not coming down. So there is this, what should I call, a very narrow balance that we have to go through, that should we allow the baby to die in the uterus and let it become a stillbirth, or should we deliver the baby so that it become a preterm death? So this is a very important balance to take, and that's how the development partners and the pediatricians and all of us are thinking that how should we strike the balance so that we can basically have a compromise here and save our newborns and the babies in the utero. So can I have the first slide, please? So in addition to this importance of ultrasonogram, in the perspective of SAFOG countries, I'll touch one or two points here. Next slide, please. Or I can share my screen. Dr. Jana, can you please share my slides? Otherwise, if I had to do it.
Give me a minute, ma'am. I'm sharing.
Can I share my screen as well?
Yeah, so you can share.
Yeah. So I'll be doing that. I have to just open my PowerPoint 1 second. Yeah. So it's here. Can you show? Can you see the screen? Hello?
No, ma'am.
No. So just. Can you see it now? Yeah, thank you. So our topic today is very important, that is the dilemma in delivery decisions. Are we suffering from having the dilemma? So we have to strike the balance between the preterm fetal growth restriction and stillbirths. So here the experts here. So for stillbirth, we know that about 2.6 million estimated stillbirths occur annually in the world, and 98% of this takes place in the low-income and middle-income countries like us. And 1.3 million, about half of the stillbirths occur during labor and birth, and most are preventable. So if we look at the causes of stillbirth, it varies in high income, in middle income, and in low income group. And in countries like us, infection is important, hypoxia is important, placental cause is important, middle and low income groups. So these are the important places, but most of the deaths are unexplained. So we have to work on that as well. Antepartum hemorrhage plays a great role. Major causes of stillbirth are these. The fetal growth restriction is one of the major causes of stillbirth. So if you look at the world's picture and concentrate in our region, usually we see that the dark is worse, but here the dark is good. So as light the maps are, the perinatal mortality rate, the stillbirth rate is high. So say in Bangladesh and in South Asia, the rate is quite high, and the Bangladesh rate is 3.4% of all births. So this is the Lancet prediction, which says that this is the curve. The red one is for the developed countries, but the green one is for the developing countries. And if we have to work very hard to bring down this and break the way of increase. And this purple line is for the South Asia. So this is for the developed countries, and this is for South Asia. And if we have to reach today's stillbirth rate, we have to work so hard. So this is the prediction which is shown in the Lancet series, and they have worked out basically a very good action plan. How can we reduce this? And there are many things among us, among these interventions. But one of the intervention is evidence of simple and cost-effective interventions. So today we are dealing with one of those interventions that we have to detect it and the vulnerable child and try to help, not so that the stillbirth doesn't occur. So we have many challenges. Our senior professors here, we learn from them that not only the technical part, we have to think about we're talking today about ultrasonogram, but Dr. Alpesh will be agreeing with me that how many of our hospitals have a good ultrasonogram machine? How many primary healthcare hospital has a good sonologist? Forget about a sonologist like Dr. Archana and the stalwarts here today. So we need so many things regarding ultrasonogram. So I think this is a starting point. Safog has picked.
Dr. Ferdowsi for giving an overview of stillbirth and preterm stillbirths which are happening in South Asia region. And I think both the leaders have echoed the same point that we really have to play safe with our area where we can really make a difference. And that's what is all about today's masterclass. And now I'm going to invite Professor Yusuf Latif, Secretary General of SAFOG, to give a little, speak few words about SAFOG. Is Professor here? Yusuf Latif?
Yusuf was here only, but I do not see him now.
Okay. And I'm really, Dr. Jaideep Tak sent his apologies that he will not be able to join the meeting. So if Dr. Latif is here, otherwise I'll hand over to Dr. Niharika to take it forward.
Thank you, ma'am, and thank you all my seniors here. And I'm sure we are all going to benefit from this wonderful masterclass today. And it gives me great pleasure to invite our chairpersons for this session one today. I would like to invite Dr. Mala Arora. We all know her She is very active and a box of knowledge on recurrent pregnancy loss. She is FRCOG, FICOG. She's been the Vice President of FOGSI in 2011. She's been the editor of International Journal of Fetal Medicine, and she's also been the editor of many books on recurrent pregnancy loss and fetal medicine. Welcome you, madam. It also gives me great pleasure to invite Dr. Sadhna Gupta. We know her as the passionate critical care specialist. She is the FOGSI representative of SAFOG 2018 to 2021. She is the member of ICOG Governing Council member, and she is the director of Jeevan Jyoti Center, Gorakhpur. Welcome you, ma'am.
So, thank you, Dr. Niharika. I think you want me to introduce the speaker now for the first session.
Yes, ma'am.
So it is my honor and privilege to present to you Dr. Vivek Kashyap. He is an ultrasonologist par excellence, practices in Delhi, graduate and postgraduate from Shimla. He has been practicing ultrasound for the last 25 years. He is the director and chief coordinator of Imaging Masterclass. He is a national executive member of IFUMB, and he is one of the founding members of the Society of Fetal Medicine and former national secretary. He has been awarded many international papers, and the list is rather long, but at the forum or at the platform of ISUOG, at the platform of FMF, he has been awarded international papers. He has also been awarded international research papers, and he has given many orations and lectures nationally and internationally. It's an honor and privilege, Dr. Vivek, to invite you. The dais is yours. And before I end, I just wanted to say hello to Sadhna, my co-chairperson, who is a dear friend as well. And thank you to Archana.
Thank you, ma'am. And before Dr. Vivek starts, Professor Yusuf is here, so we can invite him to say a few words.
Okay.
Thank you, everyone. I hope you can hear me now.
Yes.
All right. So I don't know, but thanks to COVID, we're kind of meeting right now on everybody on these things. So that's kind of a plus point if you have to take anything from that. And from SAFOG forum, I'm really grateful to Professor Ferdowsi to kind of guide us to all of us to have this kind of forum and for education and sharing our experiences and whatnot. And hopefully all this kind of things will help us manage our patients better in the future, and we'll have this learning experience more. So thank you, SAFOG, and I'm sure everybody in the end will kind of a little bit wiser about this fetal medicine a little bit more than we are right now. Okay, back to you. Thank you very much.
Thank you, Dr. Yusuf.
Thank you, sir. And I would request now Dr. Vivek Kashyap to take the stage.
Unmuted. Can you see the slides, please?
Yes, sir.
Very good afternoon to you. And before I start, just 1 minute of how it all started. And it all started with a conversation with Archana ma'am. And one fine day, we decided that we better do something because there's a urgent need for a synergy between the people who do imaging and the people who are actually managing the patients. And this is from where it started. And Archana ma'am is so dynamic that we were wondering how we can take this forward. And this was one step, and suddenly it became a giant step, bigger and bigger and bigger, and suddenly it became a huge step, and SAFOG happened. And I'm so glad and delighted that we have such a big forum right here. And I welcome, really, it brings us a lot of pleasure to see the entire subcontinent together. And as one of the speakers said, well, thanks to COVID, but then I'm sure that after COVID, we are going to physically be meeting and carrying this work forward. So my sincere thanks to Archana ma'am and Dr. Alpesh Gandhi sir and all the office bearers of FOGSI where it all happened, and all the office bearers of SAFOG. And believe me, there was another speaker Begum ma'am, who said that in low resources settings, we don't have these kind of probably the equipment and the know-hows. So let us take this another step forward, and I'm sure Dr. Archana and Archana ma'am and others will agree with me that after post-COVID, let us take this step forward. Let us go and try and train the people who are going to work in the periphery. So that is another item on the agenda, and I'm sure that the dynamic leadership in FOGSI will find some way out. Anyway, coming to my topic, and that is Doppler in pregnancy. We know that we are going to discuss about the fetal growth restriction and how to pick it up and what we can do about it. And that is to prevent the stillbirths and to detect the early growth restriction. Now there's some problem with the timing. So which means that now we presume that the baby is small. And now if the baby is small and if there is hypoxia happening, then what we can do? So before we start on the Doppler, I must thank this gentleman. He's Christian Andreas Doppler, Austrian physicist in 19th century who invented Doppler for us, and see how useful it has become. We know, of course, that in hypoxemias, which is the leading cause for fetal growth restriction, we know that reactive CTG will largely exclude hypoxemias. We also know that a non-reactive CTG is associated with wide range of pH values, and only 50% of patients with an abnormal CTG will have evidence of hypoxia or acidosis. And the CTG is likely to be reactive in the mildly hypoxic fetus and does not critically differentiate a fetal pH. So that is one of the problems in doing a CTG, where we don't really know the pH really has to fall much below before the fetus really starts showing any changes. And this is in this chart also, where we see that the non-reactive NST and the fetal breathing movements are the ones which get affected earlier. But then just to say that the fetal movements and the fetal tone, the pH has really gone down. So therefore, we need a wide change in the fetal pH to appreciate these changes. Also, this is a comparative analysis of this chart, and this is very important, where we see that the Doppler parameters are the most sensitive to even a mild change in the fetal pH. So therefore, in the Dopplers, if we do a good quality Doppler, we can pick up a hypoxia in the fetus at least 1 week or 10 days before it can be picked up on an biophysical scoring or a CTG. So then the problem comes that if there's a FGR which is happening due to hypoxemias, then there's this chance of taking the baby out, where we face the risk of prematurities, or we let the pregnancy continue but at the risk. So then the Dopplers come to our rescues. And when we talk about Dopplers in IUGRs and hypoxias, we do follow the ECU practice guidelines, which came out in 2013. And what they say, and what is the approach of protocol for study of any vessel, like for it is applicable to all the vessels that we are going to see, that is that the area of scan has to be a good B mode imaging. We need to put on the color Doppler. Our machines have to have a very good color Doppler settings. We need to look at the spectral Doppler imaging, and we need to calculate. So for that, the first step is to get a good B mode image and optimize the B mode imaging. We must optimize the color Dopplers. We must optimize the spectral Dopplers. In the following 15 minutes or so, I'm going to talk about how we can quickly try to do that, although it's a fairly long topic, but for the sake of time. And then we need to know a proper reporting format for this. But before we start anything, let us have a very important factor, and that is the maternal position. Often we see that if the mother is lying recumbent, and that may cause some problem to the mother, and that is due to cable compression. So it's always advisable to have the mother in a semi-recumbent position with a slight lateral tilt. Also, if the fetal heart has dropped for some time, then the phase of that cardiac cycle is prolonged, the end diastolic frequency shift will decline. And sometimes the Doppler indices are affected by wide variations in the fetal heart rate. So we advise that the fetal heart should come back to a normal stability before we actually start interrogating any vessel. Also, during active fetal breathing movement, there are variations in the shape of the slow flow velocity waveforms from fetal vessels, and therefore we should wait for the fetus to be quiet before we actually start doing the spectral Dopplers. Also, animal studies have demonstrated that increased blood viscosity is associated with reduced cardiac output and increased peripheral resistance. So we must have this picture in mind that, okay, there could be some sort of blood viscosity parameters of the mother in certain cases. Now, which indices to use? Now, this is often said that some people report S/D ratios, RI ratios or PI ratios. Well, these are three well-known indices to describe arterial flow velocity waveforms, and all three are highly correlated. However, PI shows a linear correlation with vascular resistance as opposed to both S/D ratio and the RI, which show a parabolic relationship. Additionally, the advantage of doing a PI is that it does not approach infinity when there are absent or reverse diastolic values. Therefore, we people by and large have shifted to PI values. Another little point is that we must be sure about the color box area and the focus, and that is, if we decrease the color box area, it will increase the color resolution and the frame rates, which means that we should not have a very large color area because then the machine is working too much. And if the machine is working too much for a very large color area, the resolution of the image will drop. So therefore, advisable, take a small little window of the color and be appropriate and only interrogate the vessel that is really needed. Also, we must remember that the focus zone should be appropriate, and we must remember that it moves automatically when the color box moves. Another issue is of the PRF values. Often we see images such as this, where the flow has bled over. It is too much of flow here. And this is because the PRF values, that is the pulse repetitive frequency values, are very low, and it should not be low. And if it is too high, then we might see a vessel which is inadequately filling. So it should not be too low, it should not be too high, it should be appropriate. How to do it? We can come some other day. Because of lack of time, we need to cover a large topic in a very short time. Also, the Doppler gate is important. We must include the entire diameter of the vessel for umbilical, uterine and middle cerebral arteries, and we know that the diameter of the gate should be the same size as that of the vessel being interrogated. Please remember, if the Doppler gate is too small, we will have a very, very stunted waveforms, and that is not appropriate. Also, the valve filters. It's very, very important because we must have a very appropriate valve filters, because if the valve filter is too high, we may see a position such as this where we cannot see the low velocities at all, and we may erroneously describe this as an absent diastolic flow, which is not really. So this is the same features done at the same time. This is high velocity valve filters, and this is appropriate valve filters. So therefore, valve filters should be appropriate, and also the speed of the spectral Doppler tracing should be appropriate. If we have too slow a speed, we'll have clumping together, and if it is too high, we'll have too few waveforms for us to have an appropriate reading. So the correct speed is about 4 to 5 waveforms, 3 to 4 to 5 waveforms in one screen, and that will show us a good separation, and we can study it much better. Of course, we must see that the fetus is not breathing, because otherwise we are going to get a graph such as a spectral tracing such as this, which could be erroneous. And we should wait, no free fetal breathing movements, no fetal movements, and no fetal hiccups also, because sometimes the hiccups will also cause a problem. So after saying in brief about all the vessels that we interrogate in general, let us go on to the first one, and this is the uteroplacental circulation. We know that in early pregnancy, under angiogenic factors, the spiral arteries will enlarge and they will uncoil, and they will why this is happening is because they allow more blood to pass through. So this is the phenomena where we know that it is conversion of the spiral arteries into uteroplacental vessels. And we must remember that these are the waveforms that we will often see, which is normal in the first trimester. This is normal in the second trimester, early second trimester, and this is what we'll see in the third trimester. Please remember, notching is normal in the first and early second trimester, and it is not appropriate to mention that or to think that there's something wrong if we see a notching earlier on in the pregnancy. What we need to do, we need to see the mean PIs and percentile to the gestational age, and that is the single most important criteria for evaluating the uterine artery flows. Please also remember that there's no critical endpoint for uterine artery indices. The pregnancy just needs increased surveillance. in case the uterine arteries are showing a high resistance, which is more than 95th centile for the gestational age. How to look at it? We are going to, I'm just going to show 1 or 2 slides on this also, because mostly we know, but for revision's sake, transabdominally, we place the probe longitudinally in the lower lateral quadrant of the abdomen, angled medially. Color flow mapping is used to identify the uterine artery as they cross the external iliac arteries. So it is the crossing of the external iliac arteries which is important. And these are the iliac arteries, and the artery which is crossing is the uterine artery. Try to sample it just before it crosses the iliac arteries. And if you cannot for some reason sample it at that point, try to sample it as close to the crossing over, and that will tell us the actual uterine artery readings. Also, please remember, we cannot overemphasize the importance of the uterine arteries in the first trimester, because that is one very important screening for preeclampsia in the first trimester. Time tested, please remember, and a very, very high sensitivity and specificity. If the PI values, the mean PI is more than 95th centile for the gestational age, that is a high risk for preeclampsia in such women. So please include all the uterine artery Dopplers in the first trimester scanning as well. Then we go on to the next one, and that is the umbilical artery. We know that what is the normal flow velocity waveform, such as this one, the one described on the right side. And this image demonstrates color and pulse Doppler flows used to evaluate the sample volume. Please remember, should be appropriate, about less than 1 millimeter. Insonation angles, that is the angle where we insonate the blood vessel, that should be less than 30 degrees to get a very good spectral Doppler tracings. And velocity should be appropriate. In this case, it should be around 180 to 100 or so. So the Doppler gate size, as I mentioned earlier, should be the same size as that of the vessel being interrogated. We must place the Doppler gate in the center of the vessel, and angle of insonation should be appropriate. It is always a good idea to study the umbilical cord in its entire length to rule out any abnormality such as a knot in the cord. Please remember, a knot in the cord may show up as a complication in later pregnancy. Earlier on, if we are not careful and if we are not studying the entire umbilical cord, we may miss a knot. But another word of caution, it is very difficult to pick up knots in the cord, and if you pick up, that's a good work done. Then we know that the umbilical artery is reflecting the placental circulation, and we must be aware that what is the normal range and the critical endpoints. We must know that this is normal in the first trimester, second trimester, third trimester, but at the same time, we must know that in the third trimester itself, if this is normal, then this shows an increased PI values, which means that the resistance is increasing. And if this is happening, this is the absent end diastolic flow, and that should ring a bell in everybody's mind. And the last one is the reversed end diastolic flow, which might be telling you to terminate the pregnancy at all costs. Now, for instance, that if there's an abnormal indices less than 28 weeks, Professor Kipros also says that if there's a reversed end diastolic flow, we assess further, and if it is at 28 weeks, we assess further for reversed, for absent end diastolic flows. So these things, a lot of papers have come out, and these things keep changing, but then generally for absent end diastolic flow, we should keep the patient in surveillance, keep the fetus in surveillance, and for a reversed end diastolic flow, please, that is a real red flag which we need to raise. So where we must interrogate the umbilical artery, either at the fetal end, free loop, or the placental end. Well, we generally prefer the free loop for the sake of simplicity and consistency. But please remember, in multiple pregnancies, I would rather go and interrogate the vessel at the fetal end, so that I know that it is the fetal A's umbilical cord and not the fetal B's. Also, please remember that the appropriate reference ranges can be different in case of a free loop or the placental end. Also, please remember, in a two-vessel cord at any gestational age, the diameter of a single umbilical artery is larger, and when the two arteries, and the impedance is thus lower. So whenever we see and we diagnose a single umbilical artery, we must keep this in mind. And also in multiple pregnancies, as I said, that we need to be very, very careful that we are not interrogating the umbilical artery of the other twin when we are looking at twin A. So PI values more than 95th centile with reduced, absent or reversal of diastolic flow needs proper surveillance or action. And if for the first time umbilical artery PI is high in otherwise normally grown fetus, repeated tracings are advised. And this is from a lot of meta-analysis over the years. So this is what we happen. This is the same fetus over 1 week apart. We can see a normal blood flow in the umbilical artery. This is increased PI in the umbilical artery. This is absent end diastolic flow in the umbilical artery, and this is reversed end diastolic flow in the umbilical artery. So it is the same fetus, and these are the changes which are happening, and this is the kind of progression of deterioration that we need to look at the fetus. Then we move on very quickly to the middle cerebral artery. We know that to take the middle cerebral artery, we need to take an axial section of the brain, which includes the thalami and the sphenoid bone wings, and color flow mapping should be used to identify the circle of Willis and the proximal middle cerebral artery, and pulse wave Doppler should be then placed at the proximal third of the middle cerebral artery, close to its origin of internal carotid arteries. So why close? Because if the fetus has suddenly decided to move, then it will not create a lot of disturbances. Also, please remember the angle between ultrasound beam and the direction of the blood flow should be as close to 0 as possible. And if the fetus is not moving, we merely move our probe to that. Care should be taken to avoid any unnecessary pressure on the fetal head. At least 3 or fewer than 10 consecutive waveforms should be recorded. The peak systolic velocity and PI usually calculated using auto trace, but manual tracing is equally acceptable. Now, what is happening in these? This is an excess probe pressure, and see what is happening. The PI of the middle cerebral artery will really go up because there's too much of probe pressure. And if the fetus is breathing, this is the kind of thing, the spectral Doppler that we get in the middle cerebral artery. And if the angle alignment is not appropriate, we will not get a very good waveform. And this is the appropriate angle alignment. So achieving the best angle is by the probe movement skill. And please remember, we should try to get a very good spectral Doppler graphs so that we can move forward. And these are the kind of normograms that we always should keep in our clinics, and preferably near where we are doing the scans, so that we can quickly refer to such a situation. So MCA abnormal waveforms, we know that this is indicative of brain sparing. So a sudden fall in PI values, if it is gradually over 2 or 3 consecutive readings, then we know that the fetus might be having brain sparing, especially if the umbilical artery is showing less flow to the fetus. And we must be aware of the brain sparing. However, please remember, brain sparing does not mean that we terminate the pregnancy. We must keep the fetus under increased surveillance because please remember, brain sparing can be transient. Overstressed fetus can lose brain sparing effect, and loss of brain sparing effect may precede fetal death. So if the PI values are falling gradually, if the umbilical artery PI is increasing, the middle cerebral artery PI is falling, and suddenly if the PI values start rising, please, that could be a cerebral edema happening, and that is a pre-terminal event in the fetus. So we don't want to see that kind of a thing. However, once we are talking about middle cerebral artery, the other major utility is that we look at the middle cerebral artery peak systolic velocity, because that is the single most important non-invasive criteria for RH incompatibilities, isoimmunizations, I beg your pardon. The other things we can look for are the amniotic fluid index, pleural effusions, hydrops, polyamnios, but the most sensitive is the peak systolic velocity of the middle cerebral artery. We should always refer to the charts, and we know that if there is any value more than 1.5 mom and a rising should alert us to the possibility of fetal anemias, and the fetus may need some transfusion at times. So what we've discussed so far is the umbilical artery. We know that the umbilical artery, the placenta really has to be attenuated more than 50% for any changes in the umbilical artery to happen. Generally 30% according to some studies, but at the same time we also must look at the middle cerebral artery to know what is the normal oxygenation and if there's any mild vasodilatation or the marked vasodilatation happening as a result of hypoxia. And then we come on to the cerebroplacental ratio. What really is a cerebroplacental ratio? We look at the situations here where the PI value of the umbilical artery is increasing, but it's still less than 95th centile. So which means that according to our laws or rules, we say that, okay, the PI value in umbilical artery is increasing and the PI value in the middle cerebral artery is reducing. But what if we just combine the two? That increases our sensitivity to check up fetal hypoxia many, many times. And what is cerebroplacental ratio? It is the division of the PI of the middle cerebral artery divided by PI of the umbilical artery, and that should generally be less than 1.05. And there are numerous papers like value of third trimester cerebroplacental ratio and uterine artery Doppler indices, which predict us the stillbirth and perinatal loss. Please remember, this also will tell us if the fetus is going to have a neurodevelopmental outcome also as a result of chronic hypoxias. So low fetal CPR in the third trimester is significantly associated with increased risk of stillbirth and perinatal loss. And this finding is independent of birth weight or expected fetal weight centile or uterine artery Doppler, suggesting that low CPR is a marker of fetal compromise. And this is one situation where now we've started using cerebroplacental ratio in all our studies. In fact, even for the growth scans, where in our clinics, when we see the patient, we must do in the third trimester a CPR to reassure ourselves that, look, the fetus is not undergoing any hypoxia and there is no such problem which is going to happen in next at least a couple of weeks. So what are the prognosticating criteria for poor outcomes? We know that if we divide these and we determine the CPRs, we can pick up certain fetus which are hypoxic, certain fetus which are liable to go into stillbirth if not terminated. But please remember, in those cases, the umbilical artery was normal or less than 95th centile, but it was the ratio which alerted us to the possibilities. So also another factor was the expected fetal weight. If it is falling less than third centile, or uterine artery PI values, if they are more than 95th centile, that should prompt us to do CPR in all such cases. Then we move on very quickly to the ductus venosus. The ductus venosus, which connects the intra-abdominal portion of the umbilical vein to the left portion of the inferior vena cava, just below the diaphragm. So once we look at the ductus venosus and we know where it is, Doppler measurements best achieved in the sagittal plane from the anterior lower fetal abdomen, since alignment with the isthmus can be well controlled. So an oblique section will give us a reasonable access for an anterior or posterior insonation, yielding a nice waveform. But please remember, the waveforms are usually triphasic, but biphasic can also be seen. The velocities are relatively high, between 55 to 90 centimeter per second for most of the second half of pregnancy, but also lower in the early pregnancy. Also, the utility of ductus venosus, we all know, is very much important in the first trimester, where we must do a ductus venosus blood flow to rule out trisomies in the first trimester, along with the uterine artery PI values. So the utility of the Doppler is very much important in the first trimester as well as in the third trimester. And these are certain techniques in which we must be careful, that this is one such case where we could see that there was some waveform below the baseline. So we thought that maybe this is due to a filter readjustments. We did readjust the filters, and then we were sure that yes, this is a reversal of the A wave in the ductus venosus and not just a little artifact or something. And that was due to adjusting the higher filters. So whenever we insonate a vessel, we must be careful about the ductus venosus diameter, about the wall filters. We know that the PRF has to be low because it is a venous blood flow. But also please remember that humoral factors, that is prostaglandins, which are given to the such fetus, can also cause changes in the ductus venosus blood flows. So ductus venosus, normal and abnormal. Abnormal is now PI values, not just necessarily we need to wait for the reversal of the A wave. We must see at the PI values, and any value which is more than 95th centile for the gestational age should alert us to the possibility that there is some acidemia happening. Aortic isthmus, this is another very, very important and a new thing coming in. It was earlier told to us about 10, 15 years ago, then it went out of practice, then it's come back in again. So it keeps coming in and out, but we must know what is aortic isthmus. The aortic arch has 3 branches. We know that the brachiocephalic trunk, the left common carotid, and the left subclavian. And the aortic isthmus is the area which is just distal to these 3 branches. And that is where we need to insonate and we need to take the spectral Doppler.
Sir, sorry to interrupt. We have 2 minutes more.
Thank you. The flow in the aortic isthmus is a reflection of both the cerebral and systemic resistances. And under normal circumstances, the direction of blood flow in the aortic isthmus is antegrade. However, the increase in placental resistance and decrease in cerebral resistance, we all know that if there's a peripheral resistance which has increased, that will happen. And if there's a brain sparing, then the fetus is going to draw more blood to its brain. And if the blood which was supposed to go down the descending aorta is pushed up into the brain, that blood is not a good blood, because that has got metabolites, that has got more carbon dioxide, and that will cause neurodevelopmental outcomes in such fetus. So to add aortic isthmus can be of lot of help, especially in those cases where we have already seen brain sparing. And these are numerous studies which have told us that aortic isthmus Doppler, transitional phase in IUGR fetuses, yes, in growth restricted fetuses, we must do aortic isthmus just to be sure that the blood flow in the fetal brain is of good quality. And then of course we have to take it a little further, especially if the fetus is just 28 weeks or 30 weeks, we can see the TIE index or the annular peak velocities, we can see the cardiac functions, and here are a lot of studies which have come up, that is the sequence of changes in myocardial performance indices in relation to aortic isthmus and ductus venosus Doppler in fetuses with early onset IUGRs. So that is all that we have in a nutshell, but we can of course take it further in our future meetings. We can discuss all this in greater details, but to sum it up, we need to know why we are conducting a Doppler. We need to know which vessel and where to interrogate. The technique has to be followed properly. We must also be aware that of the pitfalls and repeat the readings. We should be able to interpret these findings for optimal fetal and maternal well-being, and we must be able to incorporate the percentiles. Please remember, now it is the percentiles which are the most important issue, and must incorporate cerebroplacental ratio, as this is the most sensitive, and aortic isthmus studies are helpful in difficult delivery decisions. With this, I thank all of you very much for a patient hearing. My sincere thanks and gratitude, and we must take this forward, and we must have more elaborate sessions. With this, I thank all of you.
Thank you. Thank you, Dr. Vivek, for taking this Doppler talk extremely nicely and showing us the pitfalls where we can go wrong. I totally agree that the cerebroplacental ratio has improved our diagnostic capabilities of fetal hypoxia to a great degree. And I would now hand over to Dr. Sadhna Gupta to introduce the next speaker.
Thank you, Dr. Mala. It was a wonderful lecture by the Dr. Vivek Kashyap, who highlights the importance of technique of imaging, and that actually goes the way to inter-observer, intra-observer, and the time-based changes in the indices, which makes the clinician many times very confusing. So thank you very much for clearing some these pitfalls. And it is our pleasure to introduce the next speaker, Dr. Chandra Nula, who is consultant sonologist and fetal medicine specialist. And he has been ex-president, Indian Federation of Ultrasound in Medicine and Biology, ex-counselor, AFSUMB, ex-editor of the IFMB journal, and currently he is the Dean of Indian Federation of Ultrasound in Medicine and Biology. And just for our all SAFOG viewers, Indian Association of this thing, FUMB, is an association which has been conceived long ago to bring together the ultrasonologist and the obstetrician together. And with this, we are having these speakers like Dr. Vivek Kashyap and Dr. Chandra Nula. Actually, we have succeeded in the mission of our this organizing IFMB. So Dr. Chandra Nula will going to talk again on a very fine aspect of ultrasound and the clinician interplay, that is what is fetal growth restriction versus small for gestational age. So Dr. Chandra Nula, dice is all yours.
Thank you, Dr. Sadhna. I hope you can hear me.
Yes, we can hear you very well.
Okay. At the outset, I would like to thank Dr. Archana, Dr. Alpesh, Dr. Firdausi, and Dr. Yusuf for this wonderful bringing together of all of us. And I think it is so appropriate for all South Asian countries to discuss this topic, because as we know, we are the stillbirth capital of the world, especially India also. And so I'm going to talk on a very basic subject, that is SGA and FGR. It is very important to pick up a small baby on ultrasound. And as you can see here in various audits, the first step of preventing a stillbirth is picking up a small baby on antenatal ultrasound. And if you pick up a fetal growth restriction, you are reducing perinatal mortality by 50%. So this is a very, very important fact, that the most important thing on antenatal ultrasound is to pick up a small baby. And then, of course, we move on to further characterizing these small fetuses. The definition of SGA and FGR and the detection have been the most challenging problems in obstetrics from time immemorial, and we need to get these things sorted out. So the first step, of course, is definition, and we'll look into that. And fortunately, after 30 years of practice that I have been doing, we actually got a clear-cut guideline on how to classify these fetuses by the Delphi consensus. So the moment you have a small fetus, what we talk about a small for gestational age fetus is one that is smaller than the 10th centile from a population-based references. Of course, different countries will take 3rd centile or 5th centile, but as a standard, we take about 10th centile. And majority of constitutionally small but healthy fetuses will also be included in the small for gestational age. What's most important is that these are at very low risk of abnormal perinatal outcome as compared to a growth restricted fetus. So this is very, very important, that Delphi consensus definition of a small for gestational age fetus. As compared to a fetal growth restriction, this is a fetus which is not meeting its growth potential. Now this is very tricky, because how do you know what is the growth potential of any fetus, and in different countries? So as I said earlier, it depends on early detection of a fetus which is less than 10 centile on a population-based growth chart, or which is not following a regular growth curve and is falling down in various centiles, as we shall discuss. This may also include some normal size babies. So it is not necessary that a fetal growth restricted fetus has to be small. Even if the fetus is between the 10th and the 50th centile and it is falling in its growth centiles, then it is also labeled as a growth restricted fetus. What's most important is that these are the fetuses which are at risk of adverse outcome and risk of neonatal morbidity and mortality. So that is most important. And therefore, I think a new concept should be, as you know, over the years, we have changed the definition or terminology from IUGR to FGR, because we felt that intrauterine growth retardation signified something greatly wrong to the mother. And also we realized over the years that FGR is also signifying something very similar. The mothers are getting scared and saying that their babies are growth restricted. It may be good and appropriate in the future to call FGR as FRGP, that is failure to reach growth potential. And that actually signifies, really speaking, what a growth restricted fetus is going through. So does size matter? Yes, it matters, but it is not alone size that is important to classify a fetus as growth restricted. So the first step is, of course, if you have a small fetus less than the 10th centile, we monitor this, we call this small for gestational age. But like I said earlier, even a normal sized fetus between the 10th to the 50th centile, if it is showing drop in growth velocity, then that is also considered as fetal growth restriction. Or as not included in this slide, if a fetus presents straight up front below the 3rd centile, then that is also considered as FGR. But what's most important is the third angle, and that is an abnormal Doppler, as Vivek has just highlighted so very well, that these are the three components: a normal sized fetus having growth velocity drop, a small sized fetus, and of course abnormal Doppler. These are the most important criteria to diagnose fetal growth restriction. The second step is, how do we diagnose it? So it's very, very important to realize that small for gestational age is not always only constitutionally small. As we can see here, Asians are small, but that doesn't mean other problems should be ignored. So we could be having infection, it could be a nutritionally small baby, and of course, as highlighted in the introduction, the most important cause is placental insufficiency due to trophoblastic deficiency. There could be hormonal causes of fetal growth restriction, could be genetic causes, and after all ruling out all these conditions, we consider placental insufficiency as the main cause of FGR. So it's very important that when the baby presents very early at around 20 weeks, we rule out aneuploidy by our soft tissue markers before labeling something as fetal growth restriction. As you can see, this is a characteristic trisomy 18 fetus with short, long bones with growth retardation and multiple abnormalities. So we need to rule out genetic conditions. We need to look for infections and see that the growth restriction could be due to CMV infection. And you can see here extensive placental calcification, placental hypertrophy, visceral calcification, visceromegaly, and other signs of CMV. And finally, ruling out most of these conditions, we come to a final conclusion that this could be a placental insufficiency. Now, when we are dealing with placental insufficiency, there are two elements that take place in the fetal circulation. One is a perfusion defect. So the uterine arteries are bringing in less blood flow because of placental insufficiency. So that is, as Vivek has already highlighted, a high resistance pattern of flow. Or the returning blood flow from the fetus is facing resistance in the placenta because of deficiency of trophoblastic tissue. So there could be a perfusion defect. And after this, once the fetus is growing, there could be a diffusion defect from the villus into the cerebral circulation, and that is reflected very well by the CP ratio as highlighted by Vivek. So this is very basically put the pathophysiology of a growth restricted fetus. So the diagnosis would depend on various factors. We can predict at some time with serum biomarkers using them as a screening tool when you have low PEPE or AFP, that these fetuses could sometimes go into a growth restriction at a later date. Of course, diagnosis is essentially based on sequential ultrasound measurements. And as I said, if the fetus presents initially below the 3rd centile, or if there is declining or crossing growth centiles, at least 50% growth or crossing growth centiles, then we know that this is a small fetus with fetal growth restriction. And here we have to use very good ultrasound technique. And I like the point made by Dr. Firdausi that we need to train people with the good use of ultrasound. And of course, the good use of various growth curves. And the third element, of course, which not only allows us to diagnose fetal growth restriction, but is also useful in the management as highlighted by Vivek, and that is the functional parameter, that is the Doppler analysis of FGR. Now here you can see that the fetus started at almost the 50th centile, but it is following its own growth curve at the 5th centile. And very, very important, you can see that this is a 150 centimeters mother. So this probably is the growth potential of this baby because it's not dropping down. It's continuously growing at the 5th centile and the Dopplers are reasonably well. So this is seeming to be a small for gestational age fetus due to a racial variation of a small mother. I must suggest to you to use the ISUA guidelines on how to use fetal biometry very carefully and how to do good fetal biometry. Now, when you see fetal biometry, the most sensitive parameter that we use for diagnosing fetal growth restriction or a small fetus is essentially the estimated fetal weight. It has a negative predictive value of almost 99%. As also other parameters are important, but this is probably the most important parameter that we use. But now when we use fetal weight, we know that there are numerous methods of estimating fetal weight. There are almost more than 80 charts, and we are using one chart across gestation with singletons and multiples and different ethnic groups. And these can be sometimes poor predictors of fetal weight, especially when we are dealing with an extra large fetus or an extra small fetus. There's a lot of variation that we get. and the accuracy is influenced by the quality of biometry. So it's very, very important that we do very good biometry. I will not go into the technique of biometry, but it is well elucidated in the ISWA guidelines, and I suggest that you go through them before you embark upon the journey of ultrasound for detection of small babies. The next problem that we deal with is which chart to use. So there are population charts and there are customized charts, and we know that one size does not fit all. And you can see in this chart that when we are estimating fetal weight, the common equations that we use is essentially the Hadlock formula. We have various formulas, and we essentially use the Hadlock 3 formula, which includes the abdomen circumference, the femur length, and the head circumference. But the accuracy can be, as I said earlier, overestimated in the large fetuses and underestimated in the small fetuses. Now, if you see, even if the fetus is in cephalic or breech presentation, there can be a variation of almost 500 grams depending on whichever chart that you use. And therefore, this is something you need to keep in mind and include in your report. Now, these are some of the population-based charts, because if you remember in the first Delphi definition, a small for gestational age fetus is below the 10th centile, dependent on population-based charts. So we have about 3 or 4 large population-based charts, and the oldest one of them is the WHO-based population-based chart. It is meant for international use, but one must remember that there are variations across populations, and this has to be kept in mind when applied. These are essentially meant for use in these countries: Africa, Asia, Europe, and South America. And this is the chart that can be used. And fortunately today in most of our machines, we have the WHO chart and also the intergrowth chart, which is incorporated. Now, intergrowth was a relatively new entrant. It took about 21 countries, and it also is a universal growth chart, and it tells us that mothers should be growing, the fetuses should be growing at the same rate in urban populations across the globe. But if you see in underdeveloped countries, this may lead to high false positive of small for gestational age fetuses. But this was intended to be so that we focus more on these small fetuses in underdeveloped countries to improve perinatal outcome. These are, of course, having problems of population variation, and this do not include individual growth potential. And then there are customized charts which include countries, ethnicity, parental size, fetal sex, whether the mother is a smoker, whether the mother is para, multipara, and other maternal diseases. And then there are softwares, and it is essentially described by Gardosi et al. And there is a software known as the GROW software, and it's available on the net. And it's available for country-specific situations in various countries. And this can be used as one of the alternatives. And then we have the Fetal Medicine Foundation growth chart, which is a relatively new entrant in about 2018. And you can see that all these 3 various population-based growth charts will lead to the same fetus having different percentiles on these charts, and that can be a big problem. So we must use something which is a midline. Now, if you see a 36-week fetus on the 10th centile on the FMF chart, it overestimates, and it is about 2.5 kg. WHO, it's about 2.3, and the intergrowth underestimates. So I personally think that the WHO is a good substitute, a mid-variant substitute, and we all use the WHO chart once we have calculated the fetal weight by using the Hadlock formula. So if you see this particular paper, which was in 2018 from the Nicolaides' group, it said that population charts failed to improve the accuracy of prediction of birth weight, all the population charts, and even maternal characteristics were not found to be successful. And one of their conclusions was that the most accurate prediction of birth weight was by yet the old Hadlock 3 chart, which had only 276 patients in their protocol and was formulated in 1985. The estimated fetal weight was within 10% of birth weight in at least 80% of cases. So yeah, I think it's a good alternative to use Hadlock 3 with a WHO graph as giving you a guidance as to the growth velocity. So this is a good alternative. This is another very interesting paper which suggested that sonographic fetal weight estimation, is there more to it than just fetal measurements? And this is something we'll talk about in a few moments. So is it only anatomy that we should be discussing when we are talking about a small for gestational age and fetal growth restriction, or is it a functional disorder rather than an anatomical disorder? And as we have seen over the years, this is also a functional disorder. So we have to include Doppler criteria, as I mentioned earlier, when we talk about differentiating a small for gestational age versus a growth restricted fetus.
Sir, sorry to interrupt, sir. 2 minutes, sir.
Okay, so how a fetal growth restricted fetus progresses is determined by when it starts and how severe it is when it starts. So when it starts, is it early or late? And the severity, of course, is dependent on the severity of the umbilical artery abnormality. So if you see the two peaks of stillbirths that you see, one is before 30 weeks and the other is 35 weeks and above. So it stands to good reason that we are dealing with two groups of growth restricted fetuses. One is the early growth restricted fetus below 32 weeks. And the definition here from the consensus definition by the Delphi criteria is that any fetus below the third centile having an absent end diastolic flow. So both of these criteria before 32 weeks suggest that this is early fetal growth restriction. Or if the fetus is less than the 10th centile combined with umbilical artery and uterine artery Doppler more than the 95th centile. And of course, a late fetal growth restriction after 32 weeks is if the fetal weight is less than the third centile, or even if the abdomen circumference is less than the third centile, and at least two other criteria. That is, even if it is below the 10th centile, or it is crossing centiles. Like I said earlier, even a normal size fetus can be late onset growth restriction if it is crossing at least 2 quartiles or 50% quartile. And here, of course, the CPR becomes very, very important. So if the CPR is less than the 5th centile or the umbilical artery percentile is more than 95th, then again, these are important criteria for late onset growth restriction. And this is well understood by this chart. In early onset growth restriction, you have more than 50 to 70% of the placenta which is deficient. So these fetuses present early with growth restriction and with Doppler changes. If there is only 30% of the placenta which is deficient or not working well, these fetuses will grow well and present with late onset fetal growth restriction. So the role of Doppler becomes very, very important. And as you can see, even if you use absent and reversed end diastolic flow, just two criteria, you're reducing again perinatal mortality by 50%. So you can see here a fetus with high pulsatility index, normal appearing Leica, but it is crossing the centiles and now it's gone below the third centile, again suggesting that this is growth restriction. And this is the sequence of changes that you will see. I will not go into this. Vivek has already shown you, and the end point is of course reversal of end diastolic flow in the ductus venosus, as you see in early growth restriction, because you're waiting for fetus to get mature before you get delivered. As compared to late onset growth restriction, this happens on about after 32 weeks, and it's, as I said earlier, diffusion problem, and this is because of villus edema. The early growth restriction is because of villus occlusion. And this is less likely a placental problem. Therefore, here the umbilical artery can be normal as compared to early onset growth restriction where the umbilical artery flow is abnormal. Here you will get more of brain sparing effect. So the late onset growth restriction can be diagnosed by the fact that the uterine artery Doppler may be beyond the 95th centile. More importantly, the CP ratio has fallen or the fetal weight is less than the third centile. And as you can see here, this is a fetus which is falling down and high CP ratio of almost 0.61. Now, the last couple of slides, I wish to highlight the fact that even if the fetal weight is more than the 10th centile, does not necessarily reflect fetal well-being, as I said earlier. And this is well borne out from the problem that the larger number of IUFDs later in pregnancy, the fetuses are normal in size. They are AGA. They are not small fetuses. So AGA accounts for the majority of antenatal morbidity and mortality later in pregnancy. And this is again borne about by the various papers, and some of these have suggested that these babies do have placental insufficiency, which could be occult or mild, but present later in pregnancies. And you can see here a fetus essentially doing well on the Dopplers. Ductus venosus is also normal, but later on, suddenly at about 36 weeks, you can see that the Dopplers have become absolutely abnormal. The umbilical artery flow is fallen. And in this particular case, there is actually cerebral edema which has developed, and the ductus venosus has also become normal. So this, and it is a normally growing fetus otherwise. You can see that the fetus has grown well in this particular case, and it is on the 50th centile. So even if it is on the 50th centile, normal LICA, the CP ratio is altered. You have normal umbilical artery, but high diastolic flow in the cerebral circulation, and coincidentally even the ductus, although it's not important in late onset, is showing high pulsatile flow. So conclusions is that the definition of FGR is conceptual. It is the failure to achieve growth potential, which is not known in the initial part of the pregnancy, but becomes obvious as the pregnancy goes on. Whereas the smallness is actually factual. This is what you are actually measuring. In the early part of our practice, SGA was often used as a proxy for FGR, but this is not adequate. So the final messages are that fetal growth restriction should be understood as something where there is failure to reach growth potential due to environmental, maternal, or any other condition. It's a functional disorder, and therefore Doppler is central to the diagnosis and not smallness alone. Small and averagely grown babies can also be FGR with abnormal Doppler and decreasing growth velocity, even if they are in the normal range. We have two profiles, as I said earlier, early and late onset growth restriction. Early onset fetal growth restriction, the fetuses are small. Late onset fetal growth restricted fetuses may not be small, but may show falling centiles. So I thank you for a very patient hearing, and would love it if there are any questions as we go ahead.
Thank you, Dr. Chandralula. It was very, very clear and concise, and thank you very much for appreciating that even average weight fetus can have the sudden intrauterine fetal death and the insufficiency, and we have to take full clinical picture, fetal patient profile, CTG, biophysical profile, and the cerebroplacental ratio, which is very, very important. Thank you very much. Dr. Archana has said we have only 4 questions. If Niharika and Dr. Archana says we can take at this time to the speaker or after the panel, there are only 4 questions. So Archana and Niharika, if you say, or we will take after the panel.
I don't know. I think the time may be a little because many of our other panelists have commitment.
Question, that's why it is not much question, so not more number of questions, whatever you say.
Carry on.
I think you can take one or two questions, because there are a few important questions you can take.
So Archana, with the permission of Dr. Fardausi Begum, I am taking the one question is from Dr. Poonam Chawla, that is, what is the significance of persistent right umbilical vein? Anybody, Dr. Chandralula or Dr. Vivek, anybody? Significance of persistent right umbilical vein.
Okay, it's not relevant to the topic. It's a congenital variation, and it can be seen where the umbilical vein, instead of going in the midline, is on the right side, and they do well, these babies, but sometimes they can have associated pathologies, and you need to scan these fetuses and follow up. They could have other associated pathologies, but otherwise not relevant to this particular topic at all.
And then actually 2 questions are for only clinician, that if PIH has been ruled out and the Doppler is abnormal, what investigation should we have? So I think in panel maybe taking these questions, and another is in the low resource setting. So I think these 2 questions, because it is a clinical question, and we can take after the panel discussion when we have all the inputs from the clinician. So with the permission of Dr. Madharora, our co-chairperson, should we conclude the session? And thanks again, Archana, for this opportunity. And I again thanks Dr. Fardausi Begum and Dr. Yusuf and all people who are there and who have been actually continuously. We have so much of programs, and it is a real good thing to come SAFOG on a big platform, and we have the strong presence of SAFOG in our country. Thank you very much.
Very good. Thank
Thank you,
you.
Dr. Sadhana. Thank you, Dr. Mala.
Thank you everyone for this wonderful session, and thank you Dr. Sadhana and Dr. Mala for chairing this wonderful session, and special thanks to both our speakers. And we would be now heading to our second session, and I invite Dr. Apurva to take over.
Thank you so much, Dr. Niharika. I think we've had a brilliant first session. There are so many important topics that are being discussed, and the second half of it is going to get even more interesting because we're going to add the clinician's perspective as well, and it's going to be much more interactive. And in order to start the session, may I request our chairpersons, Dr. Archana Basir and Dr. Chinmayi Rats, to come over. It's my sheer pleasure to introduce these two brilliant and wonderful ladies. Dr. Archana Basir is consultant OG-GYN at Akash Hospital, Indore. And it's only today that I realized that she's actually a Guinness Book of World Record holder for removing the largest uterus. I think that definitely should go in her introduction part of it. She's also the current Vice President of FOGSI 2020, and we are looking forward to probably having a wonderful AICOG 2021 at Indore at some point. Dr. Archana has also been the chairperson of FOGSI Imaging Science Committee in 2015 and 2017, has been the organizing secretary of ISAR for 2016, and has been a vital part of many conferences that have been organized from ISAR and FOGSI as well. And our second chairperson today, Dr. Chinmayi Rat, is a director of Resolution Fetal Medicine Center, Hyderabad, and also a senior consultant at Yashoda Hospital, Secunderabad. She's an approved trainer for Fetal Medicine Foundation UK in India, and also is a moderator for ERP and MRCOG exams. She has received many awards and publications. She has received the Dr. Rajat Ray Fetal Medicine Award in 2019 from FOGSI, and has also held many posts in the conferences that have been organized by FOGSI. May I request the chairpersons to take over and start the session, please.
Thank you, Apurva. Thank you for a very kind introduction, and you really set the stage very, strong to go ahead. So thank you, and where is my partner, Chinmayi?
Thank you, ma'am. Thank you very much, Apurva.
Yes, so we can share our screen and then we can introduce the panelist. So I welcome all the panelists from SAFOG countries here on a very interesting panel, Dilemmas in Delivery Decision, Balance Between Preterm FGR and Stillbirths. So myself, Dr. Basir, and my co-moderator, Dr. Chinmayi Rat, a very, very, dedicated teacher. We are going to have a very esteemed panelist on our panel. And Dr. Chinmayi, would you introduce Dr. P.K. Shah? Then we have just taken, we will be introducing an alternate this thing. So please invite.
Well, it's an honor to actually say anything about Dr. P.K. Shah. Introducing him is not a requirement in this kind of setting. He's been the past president of FOGSI, a very passionate teacher, head of the unit in KEM hospitals, and he has a long teaching career. Often when we talk to him, he tells us about his experiences as a teacher. And sir has been the head of many organizations throughout his esteemed career, and as of now I think that his inputs in this panel will be as a very passionate ultrasonographer who thinks from the clinical point of view. And sir, welcome very much to this panel, and we'll be looking forward to your inputs.
Thank you.
Dr. Nandita Palsetkar will be joining a little late. Everyone here knows Dr. Nandita Palsetkar. She has been recent past president of FOGSI, a great academician, a dynamic leader, and very, very well liked president of people of FOGSI. So she will be joining, and we'll reintroduce her again then. And I have in my list Professor Tiran Diaz. He is a professor in fetal medicine at the University of in Sri Lanka. And basically he is fetal medicine, trained at Fetal Medicine Foundation and at St. George's University of London, and he completed advanced training and skill modules in fetal medicine, RCOG and London Deanery, and he has obtained advanced diploma in fetal medicine from the Fetal Medicine Foundation UK, and he is a recognized as a subspecialist in fetal medicine by European Association of Perinatal Medicine. So I think we have a very, very good fetal medicine expert here in our panel. So we are looking forward to very good discussion. And I have, this is my proud privilege to introduce Dr. Firoza Begum. She has been, she is the first one to come here and greet me on this, platform. She is the consultant and professor of fetal maternal unit, medicine unit and Department of Ops and Gynae at Bangabandhu Sheikh Mujib Medical University. And she was also a professor at Bangabandhu Sheikh Mujib Medical University, Dhaka, and she is a reputed gynecologist and pioneer in managing high-risk pregnancy in Bangladesh. So welcome you, Dr. Firoza, on this panel. Then
Professor Tala Abdul Halim, he is from Pakistan, currently a fetal medicine consultant there, working there since 2006 as a fetal medicine consultant. And before that, he completed his training in fetal medicine in the Royal Maternity Hospital, Belfast in 1999. And he has worked in universities abroad, has a special interest in developing this subspecialty. And we welcome him to this panel. Dr. Uma Ram, again, is a very well-known figure in India. She is the chair of the South Zone Representative Committee for the RCOG, and she is a director of the Sita Plati Clinic in Chennai. Extremely well-read person, completely up-to-date with her practices and protocols, and with a great passion towards fetal medicine. She's one of those obstetricians who understands the pulse of fetal medicine, and it's a joy to actually discuss cases with her. Welcome, ma'am, to the panel.
Dr. Purab Doroji is one of the most precious jewels of Bhutan health system. He is with very strong moral and ethical principle. He is the first chairman of Research Ethics Board of Health. Now Bhutan has better research ethics than most of the countries in the region. He is busy researcher with numerous publications, and latest one is a study of prevalence of GDM in Bhutanese women. So welcome you, Dr. Purab here. I heard you in the past also, and I'm sure we are going to have a very, very good panel here today with case scenarios. I think Dr. Asil Jalil, he's from Maldives. I don't see him here, and maybe you can go ahead.
He could not join. He could not join.
Is he there?
No, he is not here.
So Dr.
He is not here, and the person from Afghanistan is not there. He is ready, but internet is not working.
Okay, so we are short of two panelists.
But we have lots of eminent people there.
Yeah. So we can start with our next slide, Dr. Chinmay, and let's get going with this. So, you know, there's been a lot has been talked about fetal growth restriction. We had mesmerizing talks by Dr. Vivek Kashyap and Dr. Lulla, and Dr. Firdausi Begum has also pointed out the need for looking into this topic and really delivering very good services so that we can prevent stillbirths. So what have we known so far about FGR? We know that fetal growth happens from 8 to 40 weeks, and it is genetically predetermined growth potential and further modulated by maternal, fetal, placental, and external factors. So fetal growth restriction is failure to achieve the endorsed fetal growth, failure of a fetus to reach its own growth potential for that particular gestational age. You can clinically suspect it, or sonographically estimates of fetal weight, size, symmetry, or hemodynamics which can go abnormal. So in FGR diagnosis, this is the algorithm which is usually followed. That is step 1, establish the correct dating, which is the foremost important thing. Assess biometry and plot the serial growth charts, Doppler and fluids and placenta. Next. So fetal growth restriction, it is a preventable morbidity and mortality. Early diagnosis, appropriate monitoring, and timely delivery. So dilemma in delivery decision in these cases is a fine balance between iatrogenic prematurity and stillbirth. So today in this panel, we are going to be discussing cases because the clinicians usually and want to learn from the case discussion how really that particular case was managed. So over to you, Dr. Chinmay, with the case 1.
Thank you, ma'am. So this is the first case, and this is a 26-year-old primi gravida with no comorbidities, absolutely healthy before pregnancy. And she came for her NT scan at 12 weeks where the NT was normal, the CRL was 56 millimeter. So till that time, the baby's growth is also fine. But there were very low PAP-A values in her first trimester biochemistry, that is 0.2 multiples of median. The uterine artery resistance bilaterally was increased. Now with this scenario, I'd like to call in Dr. P.K. Shah. So based on her first trimester findings of very low PAP-A and high resistance in the uterine artery flows, what would you like to change in her antenatal care and how would you counsel her? When would you like to see her back? Sir, are you there?
Dr. Shah is muted actually. He has to unmute himself.
Sir, can you please unmute yourself? P.K. Shah, sir.
Okay, with normal CRL and normal NT, the low PAP-A is not going to change much the risk factor. At the same time, she is showing bilateral uterine artery with high resistance. In what range it is?
Sir, above the 95th centile.
Okay, above the 95th percentile. So now what we have to do is that she has to be put on medication. Like nowadays we start with 150 because she's a primary. We can give her 150 milligram of aspirin at the same time during day. Then call her after about 3 to 4 weeks and repeat the ultrasound. Okay.
So she did come back after 3 to 4 weeks, and at 16 weeks things were okay. And then again you called her after 2 to 3 weeks. So around 18 weeks, 5 days when she came, the growth was slowing down. It was around 9 centile. Okay. And she also met someone else and had a quadruple test. Normally we don't advise a quadruple test once the first trimester screening is done. But this lady was anxious with the report and went ahead and did a quadruple test, which came out as high risk for trisomy 21 because of abnormal biomarkers. So you did an amniocentesis and the karyotype was normal. Now you subsequently followed her up and called her around 25 to 26 weeks when the growth was around 6 centile. So there was early onset IUGR, and as you can see here, all the growth parameters are below the 5th centile. The HC is below the 5th centile, the AC is below the 5th centile, femur, humerus, everything below the 5th centile. And there's a large jelly-like placenta, there's oligohydramnios, echogenic bowel, but normal fetal anatomy. Now, this is a question now to Dr. Tiran Dias. What do you think are the common causes of such severe early onset IUGR?
Dr. Diaz? Hello?
Dr. Dias, are you able to hear us?
Please
unmute yourself. Yeah, Dr. Tiran Dias. He was interacting on the chat box. I'm sure he's with us here. Otherwise, sir, you can take this question, sir. P.K. Shah, sir, you can take the question.
He can.
Okay. So, as you have shown that there are many abnormal things at this stage. It could be number one because of aneuploidy, intrauterine fetal infections, especially rubella, cytomegalovirus, and as placenta is showing a lot of lacunae, placental lakes and all that, it could be that the placental function is affected, and if it is more than 30% affection of the placenta, means it is really damaged, then you can have early onset. Maternal nutrition does matter in especially countries like ours where the socio-economic condition has to be looked at, and what was the weight at the beginning of the pregnancy, what is the height, all those things have to be taken into consideration in this patient.
So in this case, sir, aneuploidies were ruled out because that amniocentesis was done, and fetal infections is definitely something you'd like to investigate in the background. So for that, we do a torch profile. And very early onset uteroplacental insufficiency is definitely a plausible cause here because we have uterine artery Dopplers abnormal and low PAPE. And maternal nutrition in this case was unlikely. She had a normal BMI. And so moving ahead, this was at 24 weeks. Already by the time you saw her, like sir said, more than 30% affection of the placenta was reflected by the abnormal umbilical artery Doppler at this stage. So there was absent and reverse diastolic flow in the umbilical arteries. MC and DB were normal, but estimated fetal weight was less than third centile for a 24-week fetus. Dr. Dorji, at this stage, given the background that we have discussed, what do you think? What further can you offer in this case, and what is the plan of care now?
Now at 24 weeks, with so many changes happening here, I think first thing is we need to discuss with the parents about the outcome and the possible underlying cause, and also the possible specific center, neonatal backup center, because in our setting, one of the challenges in the SAARC countries is about having the neonatal setup. So then,
even elsewhere also, I mean, for 24 weeks at that level of compromise, I think all over the world, this challenge would be there. I mean, if we are at 28 weeks, 29 weeks, perhaps we would think we are a little different from the Western world. But at 24 weeks, I think that's very rightly pointed out that it's a huge challenge to do this. So you suggest you will counsel the parents, but what will you tell them? I mean, they need an answer. When should they come back to see you?
I think if the MCA and Dr. Benosis are normal, we might be able to call them after at least, I think, about 3-4 days and review.
Okay. Any of the other panelists, do you want to think about it differently? Sir, I mean, I'm okay with calling them at 3-4 days. My point is, can we do anything different in 3-4 days?
I don't think, anyway, let the panelists.
Dr. Dias, are you back? Can you get us?
Dr. Dias, we need your opinion on this. It's very challenging.
We are now divided a bit.
Very challenging situation, very difficult, and parents want an answer.
I think Dr. Dias is in a wrong link. He is in the audience link. So I think Dr. Jana has to allow him to the main panel.
Okay. Okay.
So, and
all right.
Jana, I think we can continue with the discussion. So,
okay. So I think Dr. Shah, you can take this question. I mean, what would you do? Would you, Dr. Dorji wants to call them after 3-4 days, and we are just, I mean, as a patient, suppose I ask, what will happen in 3-4 days? I mean, if things get worse, what are you going to do?
But if you have a good neonatal setup, I think we can look at possibility of delivering by 26.
26 weeks.
Yes,
so you would at least wait till 26 weeks. My point here, sir, is that this is a very, very early onset severe symmetrical IUGR. And we are at 24 weeks. For a 24 weeks, when we talk of estimated fetal weight less than third centile, we are talking of something like 300 grams or 400 grams. And with this kind of Doppler compromise, we are actually stumped, that thing. So like the dilemmas which you're undergoing, this is the same dilemma. That's the whole topic of this discussion, you know, the dilemmas in decision. Because we want to do the best. We want to give her a baby, but she's in this situation where she's at 24 weeks and the baby is not receiving enough blood from the placenta. And the placenta doesn't look very healthy either. So like you said, after that much of deliberation, you called her back at 26 weeks. And at 26 weeks, there was an intrauterine fetal death. And she was already on ecosprin. You had already counseled her about the guarded prognosis and asked for a review after a month because there was nothing that could have been offered in the intervening period. Because if you had called her after 2-3 days also, there was really nothing that you could have done. So we were practically waiting for this event to happen because now we have a definite mode of going forward. So here, this case is just a reflection of a very, very early onset problem where we are just we are at the mercy of nature and we really don't have anything to do. But then what I would like to ask all the experts who have handled this case is, now what? She's already had the IUFD. What are you now going to suggest to that woman so that at least for her future, we have we are empowered in some way? So Dr. Dias, if you are here, you can take the question. Otherwise, Dr. Dorji, Dr. Shah, please.
Yeah, I think if you don't know, we all know the cause of death here, that it was a severe growth restricted. But at the same time, for keeping future pregnancies in mind, you have to find out exactly what are you going to do in future if she gets pregnant. So I would like to have placental histopathology also, because it was a very large placenta with many lakes inside. Yes, if she agrees for autopsy, I can go for autopsy. Most of the time they don't agree, unfortunately. And microarray, yes, I will think in terms of, but I don't know the thrombophilia screen would help in this particular patient. That is my way of looking at it.
Dr. Dorji, do you want to add anything here?
I think having a antiphospholipid syndrome screening will also help in her next.
Can you hear me now?
Yes,
Dr.
Professor
Dias,
Siran,
hello.
can you hear me now?
Yes, yes.
Can you hear
welcome.
me? Yeah, so really sorry, I was in wrong link.
So I think you've come at the right time. We are summing up that
Yeah.
first case. So
Yeah.
is there anything that you'd want to add now? Because we've had all this. Dr. Dorji just said about APLA testing. And would you
Yeah.
want to tell us when you would want to do those tests?
No, I think now this particular case, I prefer to do a thrombophilia screen after 6 weeks of delivery because
That's a
it's
very, very important point for the
Yeah.
entire audience, that it's
Yeah.
not immediately, it's after 6 weeks. Thank you for
Yeah.
that.
Yeah, karyotyping I think is not needed because somebody has done
Amniocentesis.
this before. Autopsy is needed because not for this case, particularly for this case, because we just need to find out whether baby has any other abnormalities.
And a placental
plus-
histopathology,
Yeah,
like sir
very
said.
good. Yeah,
Because
very
there
good.
is this in the condition called mesenchymal dysplasia of the placenta, and that's common, and we see that. So you would know whether it's a systemic problem from the maternal side or whether it's a placental issue which has led to the problem. Now,
Yeah.
Archana ma'am, would you want to just summarize the take-home messages in this case?
I think we had a very good inputs from our esteemed panelists. And just take home message for case 1 is severe early onset IUGR is caused by the reasons that may not be completely modifiable in the current pregnancy. I think we all agree with that. And the plan of care starts with establishing the cause and planning step-by-step management depending on gestational age. Although the current pregnancy may not be salvageable, it's important to do a thorough postnatal assessment so as to optimize pre-pregnancy healthcare for the next time. I think that is the take home from this case. And
so this first case we could not, yes sir, PK Shah sir wants to say something.
You know, when she came at 24th week, there was a time when a good counseling should have been done. She should have been told about the outcome of this particular pregnancy, that either she can have a stillbirth or we have to deliver her preterm. Because
it was done, sir. As Dr. Dorji mentioned at that point, they sat down and spoke with the couple pretty much in detail. The only thing is, because of the lack of our ability to give them a clear outcome, we call them after 2 weeks. He was mulling over the idea of calling them after 2-3 days. But since our plan of management would not change, they were called after 2 weeks. So they were mentally prepared. But as a medical profession, we felt a little sort of at loss there because we really didn't have a method of salvaging this. And this is one of those stillbirths which, you know, we cannot overcome. Moving on to the next case. Now, I think Dr. Asil is not with us. So Dr. Dias, you can take this. You missed your question in the first thing. So this is 26 years, primary gravida. Her first trimester screening was low risk and PAPE was normal here. It's 0.6 moms. We consider 0.4 as the cutoff. So less than that is considered as less. She came first time to our clinic at 17 to 18 weeks with symmetrical early onset IUGR, biometry parameters along 5th centile, no anomalies in the fetus. There's history of severe hyperemesis and maternal weight loss of around 3 kgs in the first trimester. Now, do you routinely measure maternal weight in your antenatal clinics, and what are your thoughts about routine maternal weighing?
We do serial plotting of maternal weight on our antenatal graph.
RCOG says not needed.
I know, but it's there in our routine.
So I think as SAFOG, we have to agree that this part of the world perhaps it helps. So now that you know that you weighed and you know that there's a loss of 3 kgs, would you like to ask something specific in her history? I mean, what are your thoughts in handling this IUGR?
Now, same as for previous case, I think if you see early onset of fetal growth restriction at 17 weeks, you need to have a proper follow-up plan. For her now, how many weeks is she now?
She's about 17, 18 weeks.
Yeah.
And they're giving you a history of maternal weight loss.
Yeah. Then it's better we to have early fetal anomaly scan to find out whether
Done.
this is due
It's
to...
done and no anomalies in the fetus.
Yeah. And what about uterine arteries?
That's normal.
Normal. And has she been addicted to any substances?
No. So that's what you want to have a very clear history of her dietary intake here.
Yeah.
So and any infections and illness. Basically, you are now investigating maternal environment, which might have led to this kind of IUGR.
Yeah.
Because her first trimester screening is normal, so aneuploidies is unlikely. There are no anomalies. There's just IUGR and a maternal weight loss.
Yeah.
So here, when we investigated, the family specifically gave a history of very poor nutritional intake due to hyperemesis in first trimester and the fear of nausea thereafter. She just wouldn't eat, and she herself lost about 3 kgs. So the next question is to Dr. Firoza. Now that this is established as a cause of IUGR in maternal malnutrition, how would you plan further care? Firoza ma'am, are you there?
Yes, I am here. So what is the question? How to plan?
Ma'am, this lady has lost about 3 kgs in her first 3 months of pregnancy. The baby is now showing signs of early IUGR. All parameters are less than 5th centile. And you know that there was definite nutritional deprivation in first trimester. How would you plan further care?
Yeah, definitely. This is I don't think due to the nutritional deficiency in this early pregnancy, there is IUGR in the babies. I don't believe it. And it could be something else. But still, as the mother could not eat adequately, we will give her adequate nutrition, supplementation, and there is some, regarding monitoring, there is no universal guideline regarding how we'll monitor the early onset IUGR. And but the RCOG and some other consensus meeting among the international fetomaternal experts, they say monitoring should be done both not only by the biometry, ultrasound biometry, but we also should add fetal Doppler. And in this case, we should monitor the patient in addition to giving proper nutrition and proper support. We should monitor the patient by doing ultrasound every 4 weekly, and we should start umbilical artery Doppler starting from 26 to 28 weeks every 2 weekly. And if this follow-up says that there is no problem with the fetus, that is baby is appropriately growing following the growth trajectory, and there is amniotic fluid is normal, and there is no abnormality, anatomic abnormality of the fetus, and then it is fine, and it may be a constitutionally small fetus. But if during the monitoring we see that the baby has fallen from the growth curve, or there is some excess liquor, or there is liquor is very much reduced, or there is some anatomical abnormality, then that it may be due to some chromosomal abnormality in the baby.
So thank you, ma'am. And I agree with you that we don't think of maternal malnutrition as the first cause, but then in this case, because of this very typical history, and there's a recent meta-analysis of this area of our part of the world where they say the first 1,000 days of fetal life or early life is very important, and nutrition does play a role in those cases. So like you said, this pregnancy was continued on a follow-up with high protein diet because there was evidence of maternal malnutrition early. And at 22 weeks, 6 days, the growth was on 4th centile, short long bones because all of them were symmetrically short. There was some uterine resistance, umbilical artery resistance was with positive EDF, and she was continued on high protein diet. Uma ma'am, would you just like to add here, how are you happy with what is going on here, or you want to change something now?
Yeah, thanks, Chinmay. I am happy to watch this baby grow, but I think as was emphasized, it's important that we have a detailed counseling with that couple, rule out other causes for early onset growth restriction, and ensure there's adequate nutrition and then see how the growth
Sure. So I agree with you, but she's had a first trimester screening, which was low risk, so unlikely to be aneuploidies. And the point that would clinch the diagnosis in our favor of being nutritional is if with nutrition, it starts improving steadily.
I agree.
So if it's improving, so what we are looking for here is steady growth. We won't expect it to come back to completely in the normal range, but at least there will be a steady growth and it will maintain the new curve that it has attained. So now if you see this baby maintained its curve, the graph was plotted and serially it's been growing along the same line. So satisfactory growth and the baby was taken on till full term. Now I think Dr. Thiran, you can take this question.
Yeah.
She's 37 weeks, 2.1 kg SGA. I mean, we've seen the history. We continued from that time, watched, reached 37 weeks.
Yeah.
Now, till now, growth is fine, but it's 22.1 kg. How and when will you plan delivery for her?
Now, in this particular case, since we have been managing this case throughout from the beginning, I would like to see the blood flows of umbilical artery and midcerebral artery together with the PCR or cerebral syndrome ratio. And if everything is fine, if she's 37, if mother is also willing to go for normal delivery, I would prefer her delivery we can undertake somewhere around 38 weeks by induction of labor.
Anybody wants to differ here? Dr. Dorji, Dr. Shah? Yes. Quick inputs, yeah.
I think I will disagree.
Sorry, who's speaking?
Dr. Dorji is saying something, okay. Yes.
I think we have come quite a long way up to 37 weeks. And if you have achieved there, even with the babies with no problem, the 37 is taken as a huge landmark. Now, this baby with a weight of 2.1, if you have reached to 37 weeks, and also we know that in general population, even without any problem, the stillbirth starts to rise after 37 weeks. And so it is a good time that I will not wait, but I will start to discuss with the...
So you want to deliver at 37 weeks, Dr. Diaz wants to wait till 38 weeks. And how would you deliver, Dr. Dorji, induction or cesarean?
Because everything is fine with her, this baby, so my first choice will be to discuss with the parents, give them the option, and then they should make an informed decision. And if they agree, I will be happy to go for induction of labor with
induction of labor. Dr. Shah, you wanted to say something?
Yeah, just in addition to color Doppler, you can do cardiotopography.
Sir, everything is fine. Everything is fine. From that initial nutrition issue, everything is fine. She's been growing steadily. She's reached 2.1 kg.
For follow-up every week, I think I'll wait for the spontaneous labor, but definitely not allow her to go into post-term. And she should.
Which is post-term is like 37 or 40?
No, I don't mind waiting till 48th week also, because this is...
Okay, sir is waiting till 40 weeks.
I would be inclined...
And C-section.
No, let's have everyone's input. 39 weeks.
Completed, 38 completed. Because this baby is otherwise well, it started to be small because the mother didn't have enough nutrition. Now it's
38 weeks you want to deliver. That's what Dr. Dias said. So we have two people at 38. One person is waiting till 40 and one at 37. Firoza ma'am, what are you going to do?
He can wait because everything is fine.
Till when?
The Doppler is fine. You have mentioned in this case that
everything is fine, ma'am. Dopplers are fine. The NST is fine. Everything is fine. But you're waiting till when?
We can wait for spontaneous onset of labor, but definitely we will not go it post-term. And because
not beyond 40 weeks. So if this patient goes online and looks up the experts from all the SAFOG countries, he's going to be very confused because we are going to give different opinions. Now, this is the dilemma here. You know, as clinicians, all of us are looking at this case, and we all come with the background. We've heard those lectures on Doppler, on SGA versus IUGR, on everything. But we are still mulling between 37 and 40 weeks. We don't know when to put the stop there. And that's what is the whole course, isn't it? We are balancing even if it is after 37 weeks, we don't want to deliver immediately at 37, we want to wait till 40. Now, how are we going to have the final word here? Archana ma'am?
I think maybe, you know, I would deliver around 37 weeks, give her some steroids and deliver at 37 weeks, because you may have everything going on normal, but she had initially, you know, a start when there was a growth restriction. You cannot be certain of everything. So I think
at 37 you will do a section?
Well, I'll assess her Bishop score and see if it is inducible, then yes. But 2.1 kg less than means there will be a little low threshold for doing cesarean section. I know
the experts are divided.
Not agreeing with me. Pikesha is not agreeing with me. Let him come on.
Sir, I think you're the eldest of the group, so we'll have to listen to you. But what are your thought processes? I mean, why do you think it's not wise to deliver at 37? As they said, 37 is a landmark. When we started at 18 weeks, we were not sure whether we'll salvage the baby at all.
Yes, Dr.
It's very simple. If you say that the fetal kick count is normal, hydrotocography is normal, if Doppler is normal, only because of small for gestational age, I am not going to do section number 1. I am not going to induce, and I may allow her to go into spontaneous labor, but that should be before 48th week of gestation.
So that the dilemma what we have, I think we are all understanding that, but what's like, this is I mean, in terms of experience, I think we'll have to grant him to sir that, you know, if you just wait, because why are we panicking here? This is a 2.1 kg at 37 weeks. That's definitely looking a panicky situation. But if you go from her 18-week journey, she's maintained the curve. Uma ma'am, you want to say something?
No. I'm just nodding because you can see in the growth chart, if anything, it has gone up a bit. It has not
fallen off.
Yeah,
So
of course,
at
it's difficult to interpret, but this baby is small.
At 37, it's kind of compromised, I mean, compensated for itself. And the Dopplers are still supporting. The placenta is still like more than 70% active because there are no Doppler changes in the placenta. There's no alteration of the CPR. And therefore, like sir said, with fetal kick count and biophysical profile, we are happy to, we may do intensive monitoring. We may call this woman twice weekly instead of weekly as we would do in other cases. But we can give her a chance and continue. So Ashna ma'am, take home.
I think when I think it's a very nicely discussed actually case where, you know, there was dilemma still when the growth curves were normal. So when there is an obvious maternal malnutrition is present, improving diet can alter the result. So having learned about the Doppler, fetal growth, everything, the take-home message we want to give here is that we have to, you know, look at the maternal history, and maternal malnutrition has to be corrected as well, so as to, you know, improve the fetal growth. And fetal growth assessment involves monitoring for steady positive interval growth. If Dopplers are normal, the fetus is small for gestational age, vaginal delivery can be planned at term with strict maternal fetal surveillance. So I think
this would be a case for intrapartum monitoring as well.
Yes.
We would. Yes, sir.
Whosoever is listening to all of us should not go away with impression that you give high protein diet, IVR gets improved. I think that message should not be taken.
No, so I think Dr. Archana has very clearly said only when obvious maternal malnutrition is present. Yes. Only when there is a documented malnutrition, only then the diet improves. Otherwise, diet is more of a placebo than anything else. That brings us to case 3. And I don't know whether we have Dr. Tala Hussain here.
Halim here. He was here.
So let him take. So this is a 26-year-old primea gravida with a first trimester screen. PAPA was low, 0.2 MOM, high resistance in uterine artery, started on Exosprin 150 mg per day. Scan was normal at 18 weeks, anomaly scan was normal. The uterine artery continued to be high resistance. And at 28 weeks of gestation, the growth is on 5th centile. Umbilical artery shows high resistance, positive end-diastolic flow. MCA is normal and DV is normal. So the baby is 28 weeks, growth on 5th centile, Doppler showing early changes. Now,
after 2 weeks.
Dr. Halim, how would you plan to monitor this fetus at this stage? And would you consider antenatal corticosteroids at this stage? Do we have him?
Dr. Dalla, he was here a few minutes ago.
You just repeat the history, please.
Oh, sorry, sir. So this is a 26-year-old primea gravida and otherwise no other comorbidities. And her first trimester screening test was low risk for aneuploidies. The PAPA values were low, 0.2 multiples of median. High resistance in the uterine arteries, and therefore she was started on ecosprin from that time, from around 12 weeks, 150 mg per day. 18 weeks anomaly scan was normal. Uterine artery Dopplers continued to be high resistance, but growth was within normal limits and carried on. She came back at 28 weeks when there is growth restriction, growth on 5th centile. Umbilical artery is high resistance with positive diastolic flow, and MCA is normal, DV is normal. Now, how would you plan to monitor this fetus at this stage? And would you consider antenatal corticosteroids?
Yeah, the first thing is there's no harm in giving the steroids because the general recommendation is to start giving the steroid from 26 weeks onward.
I would differ here, and I would again open it to the panel because the whole concept is about dilemmas here. So antenatal corticosteroids is a very, very important issue for management of cases where we are anticipating preterm, if not a stillbirth. So what is the opinion of the house? Dr. Tala says he doesn't mind starting steroids now. Dr. Shah?
It is stage 1 of fetal growth restriction, where you have only high umbilical artery resistance. So you need to follow her up thoroughly.
You don't want to give steroids now?
No, not now, because
Firoza,
I'm not planning to deliver her.
We
So
can
I'm
give
going to follow
steroid.
after 2 weeks.
There is no harm. There is no harm. Yes, we can give steroid at this moment.
She's
There
happy
is
to
no
give the
harm.
steroids
And
at this.
yes.
There is no harm. Uma, ma'am?
Okay, so in general, I would agree that we should consider giving the steroids only when we are at a point where we are likely to deliver this fetus within a
So
week.
in this case, will you give
No,
or will
one
you
minute.
not?
Let me just make my point. So in this case, looking just at the fetus, it is not at a situation where I think I'm going to deliver this baby within a week.
So you're not giving the steroid?
No. Just because of the fact that the fetal growth restriction Doppler at 28 weeks is not indicating to me that I am likely to deliver this baby in a week. But if I go back and remember that her PAPA was 0.2 and her uterine artery value was high, if I had actually the opportunity to do that, I would have also liked ideally to know what was her risk of developing preeclampsia. Because we are not only looking
It was
at
high. It was more than 1 in 100, which is why she was started on ecosprin.
Yes, so in this woman, in the back of my mind, I am worried that while this baby may go on for some time, there is no guarantee that this mother will not come back to me in 3 days time with a high blood pressure or 4 days time in high blood
So
pressure. And
this is another dilemma created here.
That we may have to deliver this baby because the mother is going to get into trouble from severe preeclampsia. And I think we shouldn't forget this concept while we are looking at the fetus.
Okay, so we got your point, ma'am. Got your point. Now, Professor Diaz, what would you want to do here?
Now, when we consider steroids, we should always consider both aspects, whether mother and the fetus together. Now, if mother is at the point that you are examining, if blood pressure is fine, then very unlikely that mother's blood pressure is going to go up very soon. And if endoscopic flow of the umbilical artery is positive, then it's again very unlikely it's going to be abnormal within a week or two. Therefore, I think this is not the best time you to consider. But important thing, you need to consider about her compliance. If patient is very compliant and if you could get her soon to the hospital, then I think we can withhold steroid at this point, and later on we can assess her and then consider steroid later on.
Yeah, I agree.
Dr. Dorji, no, let me just go to Dr. Dorji once. What do you think? You've already heard the others. What is your point? Give the steroid, not give the steroid?
Because her some of her Dopplers are fine and it is only at the 5th centile. There is time that we can monitor her, and I will not give steroid at this point.
You won't give the steroids. Yes, Uma ma'am, you were saying something.
No, I agree that I didn't say I'll give the steroid now, but I would keep the mother coming in more often than just the week to look at the baby. her blood pressure certainly needs to be monitored more, and we may have
How
to
often?
I mean, ideally in this woman, if she's able to monitor it at home, she should. Otherwise, I would bring her back in 3 days and have her blood pressure checked.
I think all of us are belonging to this part of the world which is not particularly very endowed, and we have low resource settings for most of our patients. So I think it would be a good idea to suggest to her to monitor the blood pressure at home, because till now she's been normotensive. She has not been hypertensive so far. Yes, she is at risk of developing hypertension, but we have to give her a plan now. So maybe she can monitor that blood pressure at home, and we can give her a cutoff. I mean, whatever based on your unit protocol, 140/90 or 140/100, and if it's more than that, she comes back immediately. And at that time, definitely you can consider the steroid with respect to the maternal condition. But given the fetal condition, as most people said, we'll defer the steroids because the best effect of the steroids is within a week of administration. And since we are not envisaging a delivery within 1 week, we are holding it so that we time it at the right time, because for all audience, a repeat dose of steroids is not something which we routinely recommend, and therefore this first dose only has to be given after a lot of consideration. Now the lady comes home for a review at 30 weeks. We had seen her at 28 weeks, so she went home, everything remained normal, her blood pressures were okay, she didn't come back. She came back after 2 weeks, and fetal growth was on 3rd centile. Umbilical artery says absent diastolic flow, MCA redistribution, and DV is normal. Dr. Shah, are you going to deliver or wait? And are you going to consider steroids now?
I think as umbilical artery is showing absent end diastolic flow, you have to prepare the patient for delivery, but not deliver immediately. If you have a neonatal intensive backup, well, it is all right. Otherwise, transfer the patient to a teaching hospital or a higher center where you have a neonatal intensive backup available for the baby in case you have to deliver. Because the growth is less than 3rd percentile, we are sure that this is a fetal growth restriction. But there is no emergency to deliver this baby right now. So, but I'll give her now steroids.
Now you will give her steroids.
I'll give steroids.
What about the other panelists? Anybody wants to hold on?
Magnesium sulfate also for neuroprotection, and I'll call her twice a week, means every 3 days, 4 days, and do her Doppler and see what are the changes. If the MCA redistribution is a good sign that there is a compensation going on in baby. But if you see that there is a reversal of end diastolic flow in umbilical artery, or MCA goes back to higher resistance, and if doctor shows high resistance, well, that is the time I would think of delivering her.
Firoza ma'am wants to say something.
I will admit this patient in the hospital because she is now 30 weeks. Growth is in the 3rd centile, umbilical artery absent diastolic flow, and middle cerebral artery redistribution. Though the doctor's menosis is normal, I will follow up this patient by doing a biophysical profile and frequent Doppler study, that is twice in a week. And we'll try to continue the pregnancy in between. We can also give a kick chart, and we can do the CTG, that is computerized CTG is better. And we can continue. It is better if we can continue the pregnancy till 32 weeks. And if not, we will have to terminate the pregnancy. But most of the authorities now agree that we should, at this stage, we should try to deliver between 30 to 32 weeks.
Let me know.
Yes, Dr. Dias, you want to say something?
Now according to truffle study, up to 32 weeks, if somebody is having absent diastolic flow, I think we can monitor either by ductus venosus or computerized CTG, and you can see the short-term variability. If it is less than 5, or DV flow, if it's absent A wave, then we can consider delivery if it is reverse diastolic flow. But when it's absent only, we can wait it to become reverse.
So what we understand is that we are ready to get alert now, but we are not ready to act immediately because it doesn't need a delivery immediately. But having said that, there is absent diastolic flow. The difference between positive diastolic flow and absent diastolic flow is the risk of acidosis starts flow. Now in the newborn, hypoxia is okay. But acidosis is something we have to start getting alert to. But
Yeah,
acidosis, sorry, you were saying?
Yeah, other thing is MCA Doppler with early onset field growth restriction is not much useful, because MCA Doppler is much more effective in late onset field growth.
Late onset. No, that's okay. But in this particular case, now that we have reached this stage at absent diastolic flow 30 weeks, we are a bit concerned. We are not comfortable, but then we don't want to immediately pull out the baby, because now again the decision to delivery, dilemma is, if we deliver, we are delivering very preterm. If we wait, we are at a higher risk of acidosis, and acidosis is something which can lead to non-reversible neurological injury. Because we are worried about prematurity and hypoxic ischemic encephalopathy both. So acidosis increases. So at 30 weeks, Firoza ma'am wanted to admit the patient. Do all of us want to admit, or what are our triggers? Why should we admit the patient? Why can't she have a home monitoring?
Yeah, this is the same question many are asking, that whether you will manage this patient at home, or will you be managing it in hospital. So I think many people's question will be answered.
So you must counsel her. Number one, if she says and she's an intelligent patient, you can tell her to do kick count at home and call her at least twice in a week for Doppler. If she cannot be relied upon for kick count, admit her. It is always safer. And always do counseling properly with the husband and wife or the close relatives, that what are the pros and cons of not delivering now, and how long would you like to wait, and what all things you would like to give her, like corticosteroids, magnesium sulfate, etc. The requirement of NICU, all those things have to be discussed with the patient and the relatives.
Thorough counseling, and depending on whether what are her situations, whether she'll be able to come back for a regular follow-up, will comply with our instructions, then we send her home. If we think that is not possible, then we admit her. And it all depends, because in some settings admission will cost the patient money. In some settings it will not be easy for them to afford that. Yes, Firoza ma'am, you want to say something?
Yeah, I want to say that this patient may need every 2 or 3 times a week Doppler study. So if a patient needs to come so frequently, it is better to admit the patient and do the test.
That's what I said. It depends on the situation where it is. We have patients who stay like 30 minutes from the hospital, and they can just drive down to the hospital. They feel comfortable staying at home and coming back. So the point is, we need monitoring. We will determine what frequency that monitoring has to be, and it has to be complied by the patient. Now, I am wondering here that in my first case, we had absent diastolic flow at 24 weeks. None of you suggested to admit that patient. But now there is absent diastolic flow at 30 weeks and all of you want to admit the patient. Why did you not do that with that first case?
Because there is no salvageability issue at 24 weeks. We are not talking about a fetus that is salvageable at 24. At 30, we have reached, and you haven't mentioned the weight, Chinmay, but that also...
It's about 680 grams.
So again, that will become very setting dependent. A 680 gram 30 weeker in some parts of India will not be salvageable. Whereas a 680 gram 30 weeker, if you're in a metro with a high, a good level 3 NICU, will be salvageable at a cost. So that also is something that we need to...
So what I wanted to drive to the audience is, absent end diastolic flow is not the indication for admission. So when you are talking about Dopplers, we get very excited that, oh, this is absent end diastolic flow. I'm going to admit, I'm going to do twice weekly Dopplers. But absent end diastolic flow at 24 weeks is a different situation from absent end diastolic flow at 30 weeks. And therefore, whenever you're looking at the decisions in fetal growth restriction, you are not going to just get driven by the Doppler finding. What is important is the patient behind that Doppler. So like Uma ma'am said, in that patient, there was no salvageability. Even if we had admitted, there was nothing that we could have done dramatic in her case. So we were not so proactive. Whereas here is a baby where we can save this baby. What we are still in a dilemma is whether now or whether later, because we don't only want survival, we want a little, better prognosis, intact kind of survival. So thank you for clarifying that. And now, how will you decide the best time to deliver cases with IUGR and Doppler changes? Dr. Halim, are you still with us? Can you answer this for us?
It it depends upon the, basically, it's not solely on the basis of Doppler studies. It's overall the patient's general conditions fetal weight, the stability of the nursery, how they're going to keep it, the Likert volume, CTG findings, combining all these things will end up in deciding the mode of delivery and time of delivery. In this particular case, which has at 30 weeks with only absent diastolic flow in the umbilical artery with the redistribution of middle cerebral artery, and no mention about the CTG, I'm not sure about, and ductus venosus is normal. I will consider to continue to monitor until there's some venous Doppler changes. And once there's a venous Doppler changes, better way to deliver this baby by cesarean section.
So this is the stage-based management of IUGR. Yes, Firoza ma'am, would you want to say something?
Yes, in case of if there is Doppler velocity is reduced, only reduced, it is not absent or it is not reversed, we can wait till 37 completed weeks. And if there is absent or reduced, then we have to think about the gestational age. What is the gestational age? If it is gestational age is more than 34 weeks with reverse diastolic flow, we should terminate the pregnancy. And again, we'll look for the early onset. If it is a symmetrical IUGR, we cannot rely on the middle cerebral artery mode. We should rely on the ductus venosus Doppler. But most of the authorities, even RCOG guideline has mentioned that we should terminate the pregnancy if the Doppler findings are abnormal and the gestational age is 34 weeks. We should terminate the pregnancy.
So I think Dr. Uma wanted to make a point here. Thank you, ma'am.
No, I only wanted to reiterate, Chinmay, that when we are talking of Doppler abnormalities, since you have put up the stage-based management and the Barcelona criteria, it's important that those Doppler changes are reproducible. And just because we get one reversal or one absent end diastolic flow, we shouldn't be in a rush to deliver, especially when we are talking 30 weekers. If we see a increase in DV resistance, it has to be a reproducible.
So I think that's a very important issue, and Dr. Vivek had alluded to that in his talk, that, you know, when you do an MCA Doppler and you put a lot of pressure on the fetal head or the fetus is breathing, you may get abnormal values of the MCA, and similarly for umbilical and all other Dopplers. So like the radiology experts had told us, we need to have a very standardized method of doing the Doppler also. The machine setting should be correct, because they showed us that even if the machine setting was up and down, you could get a false reading of that Doppler. So only when you do it under standard settings, this reproducibility will be a factor. And even for one operator, it may be a good idea to repeat it twice or thrice during the session and see that it is a like significantly abnormal Doppler, because based on that, your decision for delivery is going to change. And like this Barcelona staging, it has been done, it's very mathematical and it makes life easier for the clinician. My point of highlighting this is here is that, you know, you can just put in your checklist points that these are all what I have checked, and where does my fetus fall, and how can we decide whether we need to deliver, whether we need to wait, and whether the mode of delivery would be a cesarean section or a normal delivery. And this, again, it's accessible on the internet also. They have a online assistant. And Ashna ma'am, would you just like to summarize it for us?
Just a second. I think these are very, very useful flow chart to guide the decision. What we really had to know is, like, you know, what I say, these kind of charts can be put in the clinics also. You can make them and then you can laminate and then put, so that, you know, everybody is familiar with it. If you have a big unit, encourage the entire care team to familiarize with the protocol and balance the risk of prematurity with the risk of stillbirths. I think we have all discussed this, that what we have to do. Like, I think if it is a stage 4 ductus venosus absent, reversed end diastolic flow persisting 12 hours apart, or pathological CTG, then yes, 26 weeks. Then if there's no then you can just, I think I'm just,
you can just go stage-wise, and this chart is very much available. I mean, for
Available.
anyone who really wants this,
Yeah.
it's the Figueras article on IUGR, stage-based management of IUGR. I think it has open access on the internet also. So it's a very user-friendly and easy way of understanding things, and we'll come on. There are some more online assistance also. I think we'll come to that after
because there are many people are asking this question where we can get it. So I think Chinmay has already answered
this
it.
article is there, or you can just email us and we will send you that article. And we'll come to one more online assistant also we have on the FMF website. So I'll show that to you. You all can access it. I mean, this is free of cost and this is easily accessible to everybody. On the Barcelona stage, there is a entry for the sex of the fetus, which is a problem in countries where prenatal sex determination is not allowed. So you can just put a default male for that and just calculate it. It doesn't make a huge difference. But on the FMF website, that is also not required. So most of us can use those to find out that given this clinical situation, should I deliver or should I wait? Because you will not have this panel of experts to guide you all the time. So all of you need to make a little note for your own clinics. Now,
there is a diamond, you know, there is a question which is like everybody wants a crystal ball in their head. Like, is there is a timeline which can correspond with the Doppler changes and which tells us when to expect a delivery?
Yeah, I wish there was. There are lots of papers, but then the timeline ranges from 3 weeks to 7 weeks, starting from your high resistance till reverse diastolic flow. So it really depends on so many factors. Like Dr. Uma said, you saw absent diastolic flow, but you were more worried about the mother having that risk of preeclampsia, because if suddenly she develops preeclampsia, this whole thing can expedite itself. Whereas if the mother is otherwise normal, it could have gone for weeks together. So you have to keep balancing everything all the time.
I think you are all the time sitting on a volcano. If you have a patient like this, where they are in diastolic flow or reversing or getting absent, when every day you have to do counseling. But let's move on.
So we come to the third case now. 32 weeks, umbilical artery reversed, MCA. Okay, no, it's the same case again. So we are moving on now. The woman is still stuck with us, very compliant. Now 32 weeks, umbilical artery is reversed flow. At 30 weeks, she had absent diastolic flow. Now 32 weeks, she is reversed diastolic flow, MCA redistribution, DV high resistance, AFI is 4, and the biophysical profile has reduced to 6/8 and reduced fetal movements. Now, this is for Dr. Dias. Are you going to consider delivery now? What about steroids? And if the mother is reluctant and wants to continue, how would you counsel?
Now, since she is 32 weeks, if steroid has not been given, and I think since the EV high resistance and the reverse flow in the umbilical artery both indicates that she needs delivery. And there are two things that we have to consider. One is you need to give steroids. Other one is, because she's 32 weeks, we have to consider magnesium sulfate for neuroprotection. We need to start at least 6 hours prior by starting bolus dose followed by infusion. And you can reduce the incidence of cerebral loss by 50%.
So she doesn't agree. She doesn't want to deliver. Dr. Dorji, she comes to you. She looks up on the internet and sees that there is a specialist in Bhutan who might help me. So she sends you an email saying that Dr. Dias wants to deliver me and I don't want to deliver. I'll travel from Sri Lanka to Bhutan.
I think in this case, I think there is definite changes in the umbilical artery, but still in the doctor's Beno says there is some time that we can wait. And with the AFI,
will you tell her to travel to Bhutan, or will you tell her that?
I think I will ask her to wait for some time and get close monitor, and if she wants to continue, we might be able to assist her. With AFI 4, still there are some pocket of liquor there, so
He's complaining reduced fetal movement.
On the way to Bhutan, you shall come across India and Bangladesh. What are we going to do?
I think if she refuses, then in this, it's a critical situation, but then we need to really, in this, I think in all the discussion, what I've noted is that we as obstetricians are trying to make a decision one way. I think it's a team approach with the perinatal team, with the pediatrician, and they will be able to offer a better child prognosis after they are born. And a social worker with the consequences. Some babies, they do have problem once we deliver, and take home baby, but then there are long-term consequences also. So it is a very good point at this point of time that she should be put on the perinatal team discussion and make a informed decision regarding versus immediate delivery versus monitoring. There seems to be, if she is admitted in the hospital, we can go for some time, because we know that a day spent in utero is a much time and cost saved from the
NICU. But
NICU
you're still
cost.
in two minds whether to deliver or not to deliver. She didn't get her answer. The mail now goes to Dr. Firoza.
Yeah, I will counsel the couple. I will counsel. Definitely, we can take help from the neonatologist, maybe a team of the partner of this counseling session. But I will counsel the couple because there is reduced fetal movements. Biophysical profile is 6 and AFI is 4, and there is MCA redistribution, umbilical artery Doppler reverse flow.
I'll tell you, ma'am, what the neonatologist will say. I work very closely with neonatologists, and they tell me, madam, it's 30 weeks. Whenever you want, you deliver. When you are delivering, just call me at that time. Now, the decision to deliver is yours.
Yeah,
after 30 weeks, they don't want to talk. They are happy.
No, it is 32 weeks. So I will give a steroid, give Maxel for neuroprotection, and then deliver the baby, preferably by cesarean section.
Okay, so Dr. Dorji wanted to wait a little. Others don't want to wait. So probably we are going to deliver, isn't it? Yeah. So anybody else would want to wait on this patient now?
No.
Not really.
No,
If she
I
had,
think you have put it, if mother is reluctant and want to continue.
That's
in
right.
that case, what you can do is you can explain about stillbirth and do daily monitoring, do her AFI and cardiotocography, Doppler, and meanwhile you already given the steroids. So if she is beyond 30 weeks, you can deliver anytime. And you have to
that's what, at 32, if she refuses to get delivered and we monitor her, how frequently can we monitor her to ensure that there will not be a stillbirth?
You have to tell her to keep a kick count. Number 2,
she already has reduced fetal movements.
Reduced fetal movements, but then you have to tell exactly what is the count. And number 2, you have to do daily Doppler in this particular patient if she wants to continue the pregnancy.
So
and
is there a possibility, sir, that no, sir, is there a possibility? Is there a possibility that we did a Doppler today and rest of it continued as usual? Day 1, day 2, day 3. On day 4, she comes with an IUD. Is that a possibility?
Yes.
That's what I am. You already counseled her right in the beginning.
So we have to tell her that.
She who does not want to deliver.
So here, is it important from the medical legal point of view to take a consent from the patient that, you know, it's her decision to continue?
Yeah, I think we certainly have to explain to her the risk of stillbirth, B, the risk of neurological problems if this baby should be delivered in a greater acidotic state, and find out what is their reluctance to deliver now, because this is a couple you have had a conversation with from 28 weeks onwards. In the real world, they won't be suddenly reluctant to deliver this baby. If they are not, then if they are, then we have to understand what is the reason for the reluctance and address that.
But to keep ourselves safe also, I think some degree of that information has to be documented.
Oh, absolutely.
Because there is absolutely no sure shot method that today we did a Doppler and things were fine and tomorrow she may not come back with a stillbirth. So that is a plausible possibility in this circumstance. Now, this is what I was talking about, an online assistant. This is on the Fetal Medicine Foundation website. If you see that fetalmedicine.org, and see here in this, there's a new management calculator for SGA, and these are the contents. You know, you have to put in the gestational age, the estimated fetal weight, the whether preeclampsia yes or no, what is the umbilical artery finding, what is the MCA finding, ductus finding, deepest pool, any repetitive decelerations on the CTG. And this one they kept for short-term variation. I did not enter this because I don't think we have, in India also we don't have access to computerized CTG in many centers, and I don't think in the other countries, I mean, you can enlighten me, but I think you won't have all of us. And then you put in your other scores, and once you calculate, this gives you consider administration of steroids and delivery. That is the suggested management. Why these calculators are important? Because like I said, patients nowadays look for second opinions, multiple opinions, and they are in that habit of going from one place to another if you give them a suggested plan of management. If all of us stick to these kind of standardized methods, probably she'll get the same opinion everywhere, and the dilemma from the patient side with the reason they'll be reluctant, ma'am, is because they do a lot of research on their own, and they go through some of these advertisements in the internet, and they think that, oh, this can we can wait further, we can do further. Similar for like choice of mode of delivery or place of delivery. So too much information sometimes leads to that confusion, and these kind of online resource-based calculators help us sometime. So Ashna ma'am, would you like to do the take-home messages for this case?
Yes, certainly, Chinmay. And there were very many questions on this case actually. So, but we will be running short of time, so we will probably answer them in the next case. So what we have learned from this case is fetal growth restriction pathophysiology is now well understood, and stage-based classification is available. Fetal Dopplers play an important role in decision to deliver these fetuses, and a constant review of management plan is needed, taking the above factors into consideration, and online assistance is available from research-based resources to guide clinical decisions. And one more thing I would like to add here, whenever such kind of difficult cases you are dealing in a practice, is already being mentioned by Dr. Chinmay, that for the medical legal purposes, you should document. And may I suggest, because the copy of the document, one should be with you, because there are two types of document. One is the patient health document and one is the doctor-based document. So these are very important cases where things may go wrong in spite of the good monitoring. So keep a copy of the notes with you as well.
Thank you, ma'am. So has Dr. Nandita joined us?
I don't think Nandita's internet is gone, and
Okay,
I think we have already done a lot of discussion on this. So let's just go on this case.
So I think Dr. Halim, you can take this case. 32-year-old second gravida, GDM on insulin, PIH on 2 antihypertensives. So here the mother has GDM on insulin and PIH on 2 antihypertensives. Growth scan at 32 weeks shows fetal growth at 5th centile, high resistance in umbilical artery with positive end diastolic flow, normal MCA, normal DV. Now, what are the salient points guiding your management in this case?
Now, there are two things. There's an underlying two medical condition. One is the diabetes. I'm not sure about the status of the diabetes. You told me it's
well controlled. She's on insulin, but she's about 20 units of insulin per day and well controlled.
Okay, well controlled diabetes, and she's hypertensive and currently showing there's an increased resistance in the umbilical arteries with the fetal growth below 5th centile. So probably we'll continue to monitor with monitoring of the blood pressure and blood sugar. If it remain within normal range, I would like to review her in about 2 weeks time. And there's no immediate.
Can you reassure her? Can you tell her that things are fine?
There's no, in the presence of this double condition, one is diabetes, the other one is hypertension, so there is no way I can reassure her that there is no chance of stillbirth in this particular case. But the balance is at this moment is continue to monitor and see what happens. If her blood pressure remain within normal range and blood sugar remain under control, there's a reasonable chance that the stillbirth won't happen.
So right now we just wait and watch.
Yeah.
Now, Dr. Dorji,
Yeah, can I add one more?
Yes, yes.
Now because she's at 32 weeks, and actually we don't have previous Doppler values. Therefore, we don't know how soon that Doppler is going to be deteriorated in future. Therefore, I don't think 2 weeks interval is, I think it's more. I would prefer her to be there in weeks time to assess Doppler again.
So 1 week versus 2 weeks. That is, see, I'm telling you, this dilemma is not something created by us. It's a clinician's dilemma because of your background thought process. I mean, you're looking at so many things, so these dilemmas are justified. And here are experts who've been working in this field for years together. And still we have a difference in opinion in how we are monitoring. Our endpoint is the same. We all want the best outcome for the patient. But one of us wants to see her after 2 weeks, one of us wants to see her after 1 week. Fair enough. I mean, both ways. So what will you do? You will counsel your patient, explain your justified method of monitoring and tell them. And if your patient listens to you, fine. Otherwise, she has 5 other options to go to. So, Dr. Dr. Dorji, now what is the most effective way that you can still guarantee a good fetal outcome? You can avoid a stillbirth in this case. What is your most effective way of avoiding a stillbirth in this case?
The best thing is, I think she needs to take good care of herself on the control of the diabetes. We know that sudden changes in the blood sugar level, that is one cause of stillbirth. So she needs to keep a constant on her diet and the insulin use proper, and then secondly on taking the proper medications with the blood pressure, and if possible she should have a regular home monitoring with the diabetes and the hypertension. Both should be closely monitored. And when it comes to fetal, I think at this stage, from our point, 2 weekly, after 2 weeks it should be fine, but she should have her daily fetal kick count should be monitored, and then we will reassess after 2 weeks.
Steroids?
Steroids at this point I will not give.
Why are you reluctant when there is a risk of stillbirth? There's a risk of sudden fluctuation. Uma ma'am said in the previous one, because she was at risk of hypertension, we were thinking of steroids. Now, why are we reluctant?
Then when you give steroids, that I should have a decision that I will be needing her to deliver in the next 1 week.
And
so
she is GDM with on insulin.
Yes, so this steroid also will hamper her glucose control to a certain degree. So there needs to be a unnecessary adjustment in her insulin dose also. So since I'm not expecting to deliver her in the next 1 week or so, I can hold on until her next visit.
Okay, so that is one thing. We'll just hold on for the steroids for the time being. And I think Dr. Nandita is not here. Dr. Uma, can you please take this? What will be your indications for delivery in this scenario?
Yeah, so the indication for delivery would be either fetal or maternal. Obviously, if we are monitoring this baby, if you can go back 32 weeks, isn't it? You said where we were now. And if as you monitor the baby, the Dopplers worsen or the growth restriction worsens, then that would be an indication to delivery. If she develops superimposed preeclampsia, that would be an indication for delivery. I think there are a lot of questions on the chat box about antenatal steroids. And so I just want to reiterate that we try and minimize the steroids to a single dose, because there is good evidence that if you give repeated dose of steroids, there is an increased risk of poorer neurodevelopmental outcome in the baby afterwards. So, and if you have happened to give the steroid very early, there are a couple of questions about rescue dose. So I wonder if, I mean, if you're going to give it, that would be just a single dose, not an entire course again. Yeah, so I think the indications for delivery would be those.
Where is Chinmay?
No, I'm here, ma'am. So what we decided in this case was that the pressing factors were the maternal problems. Like, because the mother already has 2 medical conditions, you're going to monitor the mother, and in case there is a worsening of the maternal condition, despite no pressing indications with the fetus, you may still have to take a call for delivery, because that is the thing. Repeated episodes of reduced fetal movements have been considered as an indication for delivery. Would somebody, I mean, one of you want to tell me when would you think that this is significant? I mean, what is the best way of sort of objectivizing this this symptom?
I think mother is the we should listen from the panelist here.
I think you can do a biophysical profile and check on the point of clarification on the reduced fetal movement. So that gives some surety.
Biophysical profile is one option that just makes it objective on the spot. And otherwise, like if you're keeping her on home monitoring,
we usually tell her to count the kicks in the body. post meal, and should be more than 10 movements in 24 hours after the meal. So that is one.
So 10 movements in 24 hours is one option, or she takes a chart and charts it 3 times, like after 3 meals.
Yes.
We tell them to lie down on the left side for about an hour and chart every time. So if they feel 3 to 5 movements in that 1 hour, that should be kind of sufficing for that. And if she feels a definite distortion in that pattern, then she needs to report to the hospital for that. So, Ashna ma'am.
Yes, I think we are coming close to our case discussion thing, and we have learned a lot. Actually, it was a very, very interesting and intense panel on a balancing act. Still, we are in dilemma how to balance. So, but important take-home message from this case is, with maternal comorbidity, decision for delivery may be due to maternal trigger factors, and there is no confirmed evidence backed sure shot method of avoiding a stillbirth. However, reasonable care with constant counseling of family will help maintain a positive clinical situation.
No, I think that's very much the gist of what we have discussed throughout. And before we go to the final take-home points, I would suggest that each of our panelists give us one quick, after this boiling discussion for the last 1 hour, that one point which you have been really wanting to tell the audience, that you please don't go home without this message. So I will start with Dr. P.K. Shah. Sir, what is that one message you want to give everybody before we wind up?
And
One is that you should never do alone umbilical artery Doppler. You should always do it with MCA. That is first thing. And normal umbilical artery Doppler beyond 32 weeks does not mean the baby does not have fetal growth restriction. These are the two things should be kept in mind. The patient should be called repeatedly to really find out whether she is going into late growth restriction or not.
Thank you, sir. Dr. Dias?
My take-home message is that if you diagnose a patient with fetal growth restriction, and always you should write the proper plan on her antenatal record, and it should be very clear and legible, and then anybody who can read it properly, especially your trainees, because trainees you may not be the same person is being scanned next time, then trainee can follow your plan, and whatever it's flagging up, then they can communicate with you for subsequent the care.
Dr. Firoza?
Yes. Once you think that this patient has got IUGR, you must be very much sure about the date, whether it is actually IUGR or it is a mistaken date.
Okay.
It's more important. Okay. And regarding the follow-up, and if you think that this is if you have confirmed your IUGR, you should see whether it is early onset or late onset IUGR. Early onset IUGR, you should exclude the chromosomal abnormality and the fetal infection or fetal syndrome. That we should exclude. And in case of late onset IUGR, we should follow up these patients with not only with ultrasound biometry, but we should also add Doppler along with this. And we should give emphasis on the mother also, because she is the best guide whether the fetus is moving properly or not. We can give a kick chart to the mother, and accordingly we can ask her, depending on the gestational age.
What is her reaction? Yeah. Thank you so much, ma'am. Dr. Tala?
I just want to add regarding early fetal growth restriction. The karyotype is not the answer. It's only give us information about 5% of cases. And the next step is microarray, which can give us information about 25% more information than the karyotype, simple karyotype. And if the facilities is available, ideally we should do the whole exome analysis also, just to pinpoint what happened here for this early IUGR.
Okay. Would you suggest that in all cases of early IUGR, or somewhere where you're seeing some fetal factors or maybe recurrent cases?
Especially if it's a recurrent cases, patient who has previous repeated miscarriages and then conceived and then end up in
Because
this early
in a single case,
postpartum.
in a single scenario, I think a karyotype is a good step to begin with, because everyone will not have all the
For the first
facilities.
instance, that's okay,
And
but for the
suppose you get a normal karyotype, you may keep the DNA in store for doing a microarray in some cases, but a whole exome sequencing could be restricted for those cases where you have repeated issues or consanguinity in the background, or somewhere you are suspecting a genetic problem. But very important to look at inherent fetal causes. Thank you very much, sir. Dr. Dorji, any words from you?
Because today we have a wider range of audience, I think for everybody's not only restricted to fetal medicine specialists, I think it is important that once you suspect a fetal growth restriction, you should plot it on a growth chart. Whatever chart it is fine. Whether it is of any best will be customized, but then any growth chart is fine, but you need to subsequently use the same chart and try to follow the trajectory of the fetal growth. That is very
Absolutely.
reassuring.
Yeah.
Yes,
Thank you. That's an excellent point. So, Uma ma'am, one final word from you before we wrap up.
I have two quick things to say. One is, as Dr. Dorji mentioned, when you have very early onset severe growth restriction, it needs somebody dedicated to monitor that baby. And, it has to be a team that is geared. The second point is that while we do a lot of counseling about the fetus, sometimes we don't prepare the parents for a stormy neonatal period. And I think that counseling does need to happen, especially if it is in the private sector where cost comes into the equation. You find that after a few days, the parents are, starting to get anxious when they start hearing about long-term morbidity or disability. In the public sector, there's also, even though cost may not come into the equation, it's a long drawn process where that baby may have other problems, infection, need for transfusions, etc. Not just ventilation. So it's that neonatal morbidity also has to be counseled, of course, in a positive way, because we do want to give every fetus the chance to, have a good life. But we need to have that comprehensive counseling in the antenatal period itself.
So I think, thank you. Fetal medicine sprouted out of obstetrics when we wanted to treat fetus as a separate entity. But now we have realized that neonatology, pediatric developmental specialties, everything comes together, because it's not about just delivering the fetus. It's about having a good life for the child and ultimately having a good life for the entire family. So what starts with a very intense fetal medicine topic like fetal growth restriction goes on to become an entire perinatal subject in itself. And like Dr. Dorji mentioned, it's an entire perinatal team now which is going to come into the picture to get a wholesome sort of outcome to this condition of fetal growth restriction. I think with that we are kind of on the last words. I'll ask Dr. Archana to step in.
Yeah, Dr. Chinmay,
allow me to ask the question, Dr. Chinmay.
Apart from perinatal specialist and fetal medicine specialist, we have very, very experienced past presidents of SAFOG here, Dr. Chaudhary and Dr. A.B. Bhuyar. Can they unmute themselves and just give some, few words on this panel discussion and their opinions on it? Professor Dr. Chaudhary and Professor A.B. Bhuyar. And then I am going to call Dr. Firdausi for the final comments.
Mala ma'am wants to say something.
Thank you, Dr.
Yes.
About the topic of discussion today, I think it was extremely pertinent, because this is one problem every obstetrician faces day after day, and taking appropriate decision is important not only for the patient and her unborn child, but also for the obstetrician himself, for his own defense, because whether he is doing the correct thing or not. So I'm not going into details of the presentations today, which has been in depth and has been very well discussed by people who are actually knowledgeable in this field. I just want to mention that this gives us an opportunity about the potentiality of this technology to be used in future. Because, we have been attending conferences in person, involves lots of arrangements, expenditure of money and everything. But the same result, possibly in a better way, can sometimes be achieved by organizing this type of webinars. The only thing is that I think it should be more or less a regular feature in future, so that we can bring at least the people in the SAARC region, if not beyond, together to discuss these topics which are important for everybody. But and one thing only I would like to say, that this has been too elaborate a session. It's very difficult to keep people's attention continuously for such a long time. And as I have seen, the participants are decreasing as time was going on. And it is also accepted everywhere that if you continue these discussions for a long time, people tend to lose, the context. Sometimes they cannot remember what they have heard in the beginning of the session. So I think that it will be better that if these sessions are designed in such a way that they are very pinpoint and over a limited period of time, and the subjects are also very pinpointed, so that everybody is riveted to the discussion what is going on. So that is my only comment. I think this is a very good webinar, but in future we should be more cautious in organizing these in a time frame which will keep the people's attention.
Thank you very much for your comments, Dr. Chaudhary. And I think in future, we are planning a series of this kind of webinars, and we will take into account your very, very nice comments and very good advice. Professor Bhuyan, and then we can take question and answer, because there are many people still waiting for their questions to be answered. Dr. Mala wants to say something, and then Dr. Sadhna has collected questions. She has grouped them together, and there are 3-4 groups she has made. So we will answer their questions. So everybody, I would request to stay back. And Professor Bhuyan.
Yeah, so nice. Thank you. Thanks everybody. Am I in right position?
Yes.
Yes, sir.
Okay. Now this subject is very critical, and it's very difficult to come to a conclusion. Wide range of issues are there, and it is many times confusing. Science are developing, no doubt, but we are yet to reach a point of conclusion and a confirmation. So in my old days, when it just started, the IUGR and all this thing, it is early 60, but by now we have developed quite, even then, we feel a lot of confusion, and it is very difficult to come to a conclusion. However, the subject is well taken, and all the participants, they discuss nicely, and the knowledge is quite perfect, but even then, there are gap in between, and very difficult to overcome the gap. However, I enjoyed it at this age. Really, I enjoyed the young people's discussion, and I see the continuity of this type of discussion in future. And now I see Gaurav Dorji, probably I could see him. And is he here? Gaurav Dorji?
Yes, he's here.
Gaurav is here, sir.
Yeah.
Yes. Convey my salam to him, and convey my salam to P.K. Shah, my old friend, and many of our old friends I could see in this type of session, and I'm very pleased to see all the friends through this type of process of interaction. Otherwise, it is very difficult to go to Pakistan or India and meet them. So I could meet them in this type of session, and I am very much happy that we meet our old friends. So nice. Thank you, everybody. Thank Firdausi for inviting me and all my friends. Thank you.
Thank you, Dr.
Thank you,
Jan. And it was
Dr. Archana, Dr. Farooq Zaman is there, non-professor Farooq Zaman sir, are you there?
Dr. Firdausi, you can invite who are there.
Dr. Yusuf Latif, Dr. Farooq Zaman, are you there? I think this is Monday time as well. So maybe then I really thank my two, I think Professor T.H. Chaudhary and we know that Professor T.H. Chaudhary and Professor A.B. both are from Bangladesh, and from Pakistan and India, you may not be knowing them, but they are our real stalwarts. In this, not only in our clinical field, in our social field, our society, regard to our society, they are our real guardians. And they're living legends, we should say. And especially I work in the same institution with Professor T.H. Chaudhary now. He is there working, giving service as honorary at this stage age as well. And we're really grateful to him and Professor Bhuya. They are a real, what should I call, our navigators. So really, sir, thank you for being with us so long. It's a long time for you. We understand that. We enjoyed your company and your comments. Thank you, sir. Thank you so much. I think Professor Farooq Zaman is not there. Professor Farooq Zaman is the second president from Pakistan, and some encouraging. And Professor Rashid Latif Khan, I think there was another webinar in Pakistan today on child abuse. So he was there, so maybe he's tired. So with this, I thank really our seniors and all the panelists. So, thank you. Archana, I think we can commence with the rest of the...
Yeah, I think that Dr. Sadhana and Dr.
And I must, another thing, Professor Samina Chaudhary was there. She is the president of OGSP. She is there in the panel, but she is silent now. So, we thank her for her presence. Thank you so much. Yeah, Dr. Archana, go ahead, please.
Yeah. So, thank you, Dr. Firdausi, for your acknowledging the presidents of SAFOG. And we have Dr. Sadhana, just couple of quick questions for the panelists, because people have been waiting to have answer for their question. And then Dr. Mala, I think, has some comments. And then we all stay for a photo.
I have a question. I have a short, quick question.
Yeah.
If you allow.
I've actually grouped a few questions of the same subject. One is about the fecal infection, and there has been question that how much importance to be given for the torch testing, especially if IgM is normal, and if any treatment at the 24 to 26 week for the torch infection is effective. So, and the third question is how we manage the fetal infection. So, any panelist for the Chinmay or Archana, you can take about torch, what importance 24 to 26 week treatment is effective, and how to manage fetal infection. So it is about.
You can add my question to this, Sadhana, is when you're giving steroids, do you counsel about the risk of autism? Because that is also a pertinent...
a long list of questions.
Yeah, but let's just answer this.
Fetal infection and the torch. So one, any panelist or the Chinmay.
I think Dr. Mala's question was answered partly by Dr. Uma about when she was telling about repeated doses of steroids in neurodevelopment thing. So I think about the autism and all.
You counsel the patient regarding this. That was the question.
Yeah. Okay. I think so far we were not been counseling, but since we are now getting the lots of reports coming on that, it may be pertinent to really counsel the patients regarding this, because people also read the literature, they also read, and they are many of the people are, they are informed about it, they Google it. So it is important, whatever you are giving, you have to do it. You have to do a counseling.
One method of standardizing this, sorry ma'am, is that, we can make a patient information leaflet about antenatal corticosteroids. So whenever there's a situation like this, you can give that leaflet to the patient whenever, even if you are considering giving the steroids and have not given it as a, because like we discussed, there were certain occasions when we started thinking about steroids, but some of us deferred it because we didn't think we are anticipating a delivery. We can give them that information leaflet for them to read it through. Because ideally they should get enough time to assimilate that information. When it's an emergency situation, we don't have that. But
Yeah.
once that growth restriction starts in, we can give it as part of the information leaflet.
But you don't take a consent for giving steroids?
As of now, no, we don't take a separate consent. I don't know what's the protocol in other units, but we have not ever taken consent for steroid, especially only in cases of diabetes, like when we have to admit the patient for inpatient insulin monitoring. It's kind of a documentation, but otherwise, no. Uma ma'am, do you
I
take a
think
consent?
we document a discussion, Mala. That's what we tend to do. And we assume that when they take the injection, the consent is implied. But we have to ensure that there is documentation of the discussion as to why we are giving the steroids. And I certainly, the practice of giving steroids every month, which we sometimes see in many practices, certainly has to be has to stop. And yeah.
That question on fetal infection, I would like to address that because yes, we do the torch profile in the mother. In some cases, like, in our country, we have the upper limit of 20 weeks for termination of pregnancy for a fetal indication. So very many times when the situation arises at 18, 19 weeks, when we're doing an amniocentesis for the karyotype, we also ask for a torch PCR. That is possible now. So you can, in summary, rule out whether there is an infection from any of the torch organisms at that point. Suppose we have not done an invasive test and the IgM is negative and the IgG is positive. Most likely this infection is not an acute infection, but we do a test called avidity of the IgG, which gives us a timeline whether this infection was less than 4 months or more than 4 months. So if that infection was before 4 months, it's unlikely to have affected the present pregnancy. But if the infection is rather recent, then we would suggest doing an amniocentesis for a torch PCR. Should you find a torch organism, it depends on that particular organism what the outcome is going to be. For rubella, we really don't have a treatment. If we have documented rubella infection, most of us tend to advise termination of the pregnancy. CMV, again, the treatment modalities are there with some ganciclovir and other medicines, but it's all very under research settings, and there is a high risk of sensory neural hearing deafness later on. Treatment has not been extremely effective in terms of CMV. Toxoplasma is the only infection for which there is in utero treatment available. You can give a spiramycin to prevent mother-to-child transmission if it's not already seen in the amniotic fluid, and you can give sulfamethoxam pyrimethamine combination for treatment of toxoplasma. And it works. I mean, see, once the fetal infection is proven, it will always be a percentage success. But if the parents want to continue, then with toxoplasma, you can continue with treatment.
Thank you, Chinmay. Actually, these answers really gets make things complicated also, because how many times we can have this really torch PCR and how this thing. So science is there, but the dilemma of clinician remains. So
absolutely,
I think I have answered quite well all the questions about the treatment. And now coming to the second part, I think we will take for steroid and the magnesium sulfate for neuroprotection and for protection. So one question is, does steroid protect against autism as well? Secondly, diabetes, I think panel have already, Archana has said that for the diabetic, we have to admit the patient. And next up, how to go about in the practice in the South Asia to prevent neuroprotection and in what dose. Next up, there are a lot of questions on the dose, route, and when to do. So anybody, any expert can.
Any one of our panelists want to answer this? That's fine. Otherwise, we'll take it. Dr. Dias, Dr. Dorji, anybody?
Dr. Uma or Dr. P.K. Shah?
Dr. Uma, about the
magnesium sulfate for neuroprotection. Anyone wants to take it?
Yeah, it's the same dose as for preeclampsia. We tend to give the loading dose IV. I prefer not to give the IM, 2 grams intramuscular. It's extremely painful for the woman, and at least 4 to 6 hours before delivery. So if you're anticipating that you're going to, in the context of a growth restricted preterm, usually it will be planned, so we know. In threatened preterm, if we need to give it and then the preterm labor does not progress, then you can stop. But otherwise, till 32 weeks, there is evidence that it is helpful.
There are role and medicine also act as a tocolytic as well. Actually, also act as a tocolytic. So sometimes it will preterm labor. It is a third question, which is again very, very important and pertinent for clinician: drugs in the IUGR. So question about the sildenafil, question about IV amino acids, question about arginine, that whether they are effective or not. So we want a very neutral and clear answer for all these drugs: sildenafil, arginine, IV amino acids, and IV albumin for the treatment of growth retardation. And many people are doing also IV infusions. So yes.
I think for sildenafil, it's very clear that there is a safety statement against the use of sildenafil in IUGR as of now, because the last trial that was being done on the sildenafil did not work out well, and it also led to some mishaps. So no sildenafil in IUGR as per the present standards till we get a better, research result for that. Regarding IV fluids and amino acids, I'll let one of the clinicians answer, because that's an obstetrician's favorite of pushing in IV amino acids and this thing.
And arginine anodonus.
I don't know if anybody else
Dr.
wants.
P.K. Shah, Dr. P.K. Shah wants to answer.
I want to ask question to both the moderators.
Yes, sir.
Is it possible?
Yes, sir. Please.
Okay. What is your take on routine third trimester color Doppler so that we can pick up late IUGR? What is your take on it?
Absolutely, sir. You answered it. We must do it because we would even
loudly,
if,
I'm sorry.
I said, as you said, I completely agree that it has to be done, because even if we are doing a routine scan in the third trimester, which is around 34 weeks, if we do not do a color Doppler, we will miss out the cerebroplacental ratio redistribution, which was alluded to in the previous talk. So it must be done. There is a section of fetal growth restriction that will still be within the 5th to 95th centile. There might be a change in quartiles of the growth, but the baby might still be above the 5th or 10th centile, and it might be growth restricted. So that is late onset IUGR, which we will miss if we do not do the color Doppler in the third trimester scan.
Because when I was reading from London group, Dr. Ranjit Akolekar, who did MD from Sion Hospital, when I was there, he has come out with a very categorically that if we will have to in future do a routine third trimester color Doppler so that we don't have unexplained stillbirths in late onset IUGR. So that is something which we must keep in mind.
I will
As a
like
fetal medicine expert, I agree, and we should be doing. But there was a question, I think, Dr. Sadhana, what we should be doing in low resource settings and in poor conditions where people cannot afford to come for routine Doppler studies and ultrasound. Is there any other method which they can adopt to pick up the IUGR? I think this was a very...
One thing, Archana, which can I do only from the personal... I always put on the Doppler whenever I or my ultrasonologist do ultrasound after 32 weeks, and we don't charge anything. We put on umbilical Doppler and we put on MCV. This is one way to, like, for low resource setting, because we, Archana, we both are working in the same field, and Madam Firdausi and PK Shah teachers from whom I have learned ultrasound. Actually, we have to make every obstetrician a fetal medicine specialist. And always obstetricians are having like the resource on the fees and the time. So one thing is that our aim should be every obstetrician should be fetal medicine specialist. If not 100%, at least 60 to 70%. Again, to sildenafil, Chinmay, I have faced 2 intrauterine fetal death in IUGR when the big companies and the big places promote sildenafil and we use. I have also suffered 2 IUFD with the sildenafil. It is something very wrong. And this question, Dr. PK Shah, what to do in low resource setting to, beside this is my personal, but on the wide range, how can we investigate these IUGR in a low resource setting. So Dr. P.K. Shah and Dr. Uma, anybody can.
Sorry, could not hear you.
Low resource setting. How do you monitor?
Sorry, low
resource setting.
Okay, no ultrasound.
Middle income countries, yes.
No ultrasound.
Maybe not.
Do
No
fundal
resource
height.
ultrasound, sir.
Fundal height, I think, is the best way you can get at least some doubt as a clinician that if the fundal height is lagging by more than 4 centimeters than what is expected for that period of gestation, you will at least a suspicion that probably there is something wrong with the growth of the fetus. That is the only thing I can tell you. But I don't think there is a small, even primary health centers have been provided with sonography. And I feel at least in our country, things have improved drastically. And the medical officers who are in charge of primary health centers also have undergone training in ultrasonography, and they are good to do at least basic ultrasound.
Dr. Fardosi wants to say something.
I want to say that Dr. Purab, let me just finish within 1 minute. I think the infertility specialist has some guideline, like the guideline for the primary physicians, guideline for the second line, like general obstetrics and gynecology, and then the specialist. I think from the fetal medicine side, we can have some protocol like that. I think there are some, because I think even antenatal care are done by GPs. So how the GP should monitor. And then, like Dr. P.K. Shah said, that it's the fetal monitor, fundal height, fetal kick count, and those kind of things. And then gradually, the stepwise, we can have some guideline. And naturally, everybody cannot be Archana. Everybody cannot be Dr. P.K. Shah. Everybody cannot be Dr. Kashyap. But we need further specialists to say for very, very high risk cases. But for the general people, I think we should have a general guideline. Thank you, Dr. Darji.
When it comes to having a routine scan for everybody, we all know that we don't have a standardized approach, and then the issue of accessibility also is there. What we do in Bhutan is that we know that the late IUGR, a scan has to be done after 32 weeks, anywhere less than 37 weeks. So we have struck a balance that we recommend all the pregnant women to have a scan around 36 weeks to pick up the late IUGR. So I want to share with others. So that's a simple growth scan done by trained midwives or ultrasound technicians. So when they pick up from that routine scan, and then they can filter out with a growth restricted fetus, so then they are referred. So that's how we manage in our country.
Thank you, Dr. Dorji. I think we are now coming to sum up this panel discussion, question and answer. I think it was a very, very intense discussion, and there was a good attendance as well. And I think people were here till end. And it was a very good knowing from different parts of the SAFOG countries how they are really taking, different ways in preventing the stillbirths and identifying late IUGR and early IUGR. So thank you, everyone. And I think we just wait for one picture. And I would like to thank Dr. Jayanta Jana from Formed, who have really done a good support in audiovisual. I think we had a seamless audiovisual, and there was no problem in that. And they were very, very supportive in connecting to all of us. So thank you, Dr. Jana. And would you like to say some words here? Are you still here, Dr. Jayanta?
Dr. Jayanta must be there, and we must listen.
I am here. I am here, ma'am. Thank you very much. I mean, I am an oncologist by profession, but it was like going back to my college again, and it was a rejuvenating experience. And I would like to thank you all for coming under and giving us this opportunity. And we'd like to continue this relationship, maintain this relationship, and also to do better programs in the future. And I would be waiting for your all to be coming into the screen, and I will be taking a snapshot. I think everybody is in the screen.
Yes, I don't know
Yes.
whether it is.